Um, good morning, everybody. I would like to, first of all, turn my mobile phone off. Secondly, I would like to say it's a pleasure to be here and obviously thank Carlos and Carlos, which I suppose make it Square Carlos, for the invitation and the opportunity to be here once again. And there's no better way for me to start my day than to introduce Professor Yehuda Schoenfeld. There's too many things that can be said about him. I choose from all of them to say that he's been a very good friend for a long, long time, probably more than each of us cares to remember. And it has been a pleasure over the years to see him learning and most of all teaching all of us about new ways of looking at autoimmunity. So I give you Professor Schoenfeld.
There in Greece. So suddenly to see all of you together, which I see here about 150 people, it's very, very emotional for me. Therefore, I prepared a special talk for you, which incorporate several aspects together. How do we develop autoimmune disease? And this is one of the main issues in this meeting, which the Carloses are organizing. But then to switch a little bit to say why the COVID is an autoimmune virus, and moreover to say why the post-COVID syndrome is typically an autoimmune one. It was not easy to get here. I came here yesterday, and I think that my hypothesis was completely destroyed by the corona testing. And I am living from here to another 2 cities. And in these 2 cities, I am running after the corona test where I can do the corona. So this will be our life in the future. To get along with the flight, to see all the tests and all the documents that we are supposed to be done. To those friends who are here and that I didn't have the time to speak with, as you can see, I was nominated as a president of the university, which is called Ariel University. It's a beautiful university of 17,000 students. We have special faculties, needless to say, from medicine to science, etc. But we also have a special research in what we can call archaeological aspects of Israel. And they have found the seeds of wine in old jars in Judea and Samaria, which were dated to the time of King David. And they grew them up. And they have now a wine, which is believed to be the wine that King David in the Bible drank. You can see the bottle. Those who will come to visit me, the Carloses and other friends, Antonio and so forth, you will get a bottle of this wine, which is regarded as very high, 4.2, something like that, as you can see. So wherever I go, I show this bottle. It's not a competition to Porto's wine, but it's a wine, our wine. It's a biblical wine, etc. Wherever I show it, I went to another city in Russia, and when I showed it, they gave me the Delta wine, which is the COVID wine, as you can see here. So I would like to concentrate about the COVID-19 as an autoimmune virus and to summarize two aspects which play in concert to induce autoimmunity. One is hyperstimulation of the immune system. The virus really is a strong adjuvant per se, so it belongs also to the adjuvants. It's similar but stronger in the stimulation to the EB virus, to the Epstein-Barr virus or the cytomegalovirus. But the second is that there is a molecular mimicry between this virus and our body constituents, and therefore it enhances the ability to induce autoimmune disease in different organs. This morning, on Fridays, I have my Fridays Mosaic of Autoimmunity webinar with all the world. You are invited to join, it's free. And it's 2 hours. The only problem that you have to wake up at 5:30, which I did this morning for 2 hours. And we talked about the ocular aspects of the COVID, and there are many ocular aspects to this virus. So basically, how do we develop autoimmune disease? We need genetics. You have to be born to the proper father and mother. And then you need some kind of an environmental factor to stimulate your immune system. And as you will see, there are also some kind of endocrine aspect, which again are associated with hyperstimulation of the immune system. And this very simplified scheme was actually suggested by Noel Rose, the father of modern autoimmunity, who unfortunately died a year ago. And I like to show it. Having said that, we have expanded this scheme, as you can see, to genetics. And as you will see, genetics means many genes and many markers, not one, to just expand the field of mosaic of autoimmunity. But some of the well-known are the HLA-DRB1 and the gene PTPN22. So, as you will see later on, what actually characterize these carriers of these genes or HLA, it's hyperstimulation. And then you have additional stimulation from the environment. It can be by infectious agents like the COVID-19. It can be by adjuvants from vaccines or other infectious agents, or from silicone breast implants, which are great adjuvants, and eventually you develop autoantibodies. Needless to say that estrogen are quite important to explain why 83% of all autoimmune diseases affect young women at the childbearing age, because the estrogen also hyperstimulate the immune system. When you measure the titers of a COVID vaccine or COVID infection, you will find that women always have higher titers than men, and it pertains to all infectious agents. At the beginning, you develop autoantibodies, but this does not mean to say that you have autoimmune disease. But if you take times, these autoantibodies may be pathogenic, and you will develop an autoimmune disease. If it continues the hyperstimulation, you will develop lymphoma, like in Sjögren's syndrome, which is a classical autoimmune disease. This was our book, which we published in 1989, The Mosaic of Autoimmunity. I thought that I understand autoimmunity, but 30 years after, when we edited the new edition of the Mosaic of Autoimmunity with Carlo Pericone, we have learned that we didn't understand too much, and still we have a lot to learn. And one of the questions that we were able to decipher after a lot of studies are the genetic markers of autoimmunity. And as you can see here, these genetic markers are shared by many autoimmune diseases like the HLA-DRB1 or the PTPN22. And there are additional factors which will decide if you will develop rheumatoid arthritis, multiple sclerosis, or systemic lupus. What characterizes people with HLA-DRB1? Why they are so prone to develop autoimmune diseases? And it was an enigma which was solved and published in an unknown journal called Nature, as you can see. And it was found that those people who have the HLA-DRB1 have actually a very strong, effective immune system, like women. And therefore, a woman with HLA-DRB1, she has a, I would say, very aggressive immune system. And therefore, when there is an additional stimulation, then the autoimmune diseases will actually emerge. This is just one table from our paper to show that in every disease, autoimmune from SLE to psoriatic arthritis, from multiple sclerosis to rheumatoid arthritis, you have an increased incidence of HLA-DRB1. And this is the paper in Nature, which show that those who carry HLA-DRB1 haplotype, they have a stronger immune system, therefore they are more resisting infections, including the COVID-19. However, when they are exposed to a stimulation from the environment, they are the one who will be prone to develop autoimmune disease. Do I have a proof of concept to my theory here? Yes, we have many proof of concept. I will just stay on 2 points. One is the checkpoint inhibitors, which was reported by Allison and Honjo, and they were granted the Nobel Prize about 3 years ago. They said, why we cannot overcome some cancers, like some leukemias or some solid cancer, because we have checkpoints which inhibit our immune system to attack the cancer. Let's inhibit these checkpoints and let the immune system be aggressive, then unleash it. And they did it. And indeed, they won the Nobel Prize because they enabled us to overcome additional 25 to 30% of uncurable cancer. But by putting a hyper-stimulated immune system, the toll, and this is not money, this is the toll, is autoimmune diseases. Actually, there is no organ in the body that was not reported to have an autoimmune disease that emerged following the checkpoint inhibitor. Who developed the checkpoint inhibitor? Those who carry HLA-DRB1. So you have genetic with HLA-DRB1, you hyperstimulate it by inhibiting the checkpoint inhibitor, and you will develop autoimmune disease. Another concept of, another proof of concept is the silicone breast implant, as you can see here. Women with silicone breast implants complain about many funny that we as a physician sometimes cannot understand. How come that they have this cognitive impairment, memory loss, dry mouth, dry eyes, paresthesia, hearing loss, etc. So most of the physicians cannot handle it, so they send them to hundreds of MRIs and CTs, etc. So in any case, first of all, it's an autoimmune disease. This is a study that we have published in Journal of International Journal of Epidemiology, very high impact factor. We compared the incidence of 24,000 women with silicone implants to 100,000 control healthy women, and we found that they had all autoimmune diseases more prevalent than in the non-silicone implants, as you can see here, from lupus to sarcoidosis, from multiple sclerosis to other. Who among the women develop the autoimmune disease? Those who carry the HLA-B1 haplotype. So again, we have the genetic preponderance, we have young women, to those we are implanting the breast silicone, and we have the silicone implants with the HLA-DRB1, the environmental factor, which plays like an adjuvant. So as you can see, the same story comes with COVID-19. COVID-19 is a hyperstimulator of the immune system. It destroys a lot of organs according to the presence of ACE2 angiotensin converting enzyme 2, and therefore it causes hyperstimulation, and eventually the women or the men develop autoantibodies in this case, as you can see, and eventually autoimmune disease. Who among the population would develop autoimmune diseases? Again, HLA-DRB1 haplotype. So we need the genetics, which denotes actually people with very aggressive immune system, and women at the childbearing age, which have a better immune system than we poor males who are not contributing a lot to the evolution. Women are the incubators, and we need the stimulation of the immune system from the area. But I mentioned in the beginning of my lecture that it's not stimulation alone. We did a screening of the peptides in the spikes of the COVID, and we found many of the peptides having a molecular mimicry with our own organs, and therefore there is a panoply of different autoimmune diseases and autoantibodies which are generated following the COVID-19. And here you can see the two mechanisms, the one which is the hyperstimulation of the immune system and the molecular mimicry. Needless to say that there is an inflammation, cytokine storm, etc. And then eventually we develop the autoimmune diseases. Do we have evidence for them? It's plenty. Actually, we are now editing a book on autoimmunity, COVID, and post-COVID. And if anybody, Laurent, if you want to join us, you can join us if you want to contact me. But we have a very close deadline because we want to be the first book in the market with the autoimmune aspect of the COVID and post-COVID. So here you have just a short list of different autoantibodies that were generated by the COVID-19. But if there are also autoimmune diseases, the answer is yes. We have published a seminal paper also of 27 cases of different autoimmune diseases. Some of them are rheumatic, some of them are generalized autoimmune disease from ITP to antiphospholipid syndrome. And in the regular one, you can see from myasthenia gravis to type 1 diabetes. So we drew this beautiful picture by the student Arad Dotan, who is a co-editor with me in the book, in which we summarize more than 18 different autoantibodies generated by the COVID and more than 18 different autoimmune diseases, from Kawasaki disease to vasculitis, from autoimmune hemolytic anemia to, if you can see, emergence of systemic lupus erythematosus. So what about the vaccine of the COVID-19? By and large, there was a revolution here. It's not that I'm against vaccine, but I am a supporter of the fact that if somebody got a vaccine with adjuvant and developed autoimmune disease, somebody has to compensate her or him for the fact that they developed the autoimmune disease. And in the United States, where I appear in the court, there is a special court just for vaccine-related, I would say, autoimmune aspect. And for years, I said, listen, think about a novel aspect of vaccine, which will not contain adjuvant. The companies didn't tell us, because the companies make $1 billion on every vaccine. Remember, vaccine immediately goes to healthy people all over the world. So they didn't tell us that they had in their cellars a new system of vaccination, which was called messenger RNA. Only now they came up because they didn't want to spend money. But now the government, especially the United States government, said money is not an issue, go ahead. And they pulled out the messenger RNA. And the messenger RNA, luckily enough, does not have a strong adjuvant vaccine. Doesn't mean that you skip the molecular mimicry, because also the messenger RNA contained, but you would expect less autoimmune diseases. But actually, as you can see, the vaccine were distributed. And this is just a cartoon showing two mice who talked to each one and said, oh, wait, I don't want to be vaccinated until the experiment in human will be finished. And indeed, Israel, my country, was the first one with this vaccine. As you can see, sometimes there are mistakes also with vaccine. You see where this doctor has to change his eyeglasses and he injected the wrong place, etc. But in any case, we have published 27 cases together with an United Kingdom researcher of different autoimmune diseases, which were developed after the SARS, the COVID-2 vaccine. So we recommend the vaccine, but we have to recognize, to be aware also of the different autoimmune diseases. And to my opinion, they should be compensated in case that the autoimmune vaccine consists. These are some of the vaccines, as you can see, generalized autoimmune diseases and some rheumatic diseases, from myasthenia gravis to multiple sclerosis, and from SLE exacerbation to other. Here you can see even a gouty arthritis. You can see 2 cases of severe arthritis, etc. Post-COVID. As you can see, this is the University of St. Petersburg. This is the longest building in the world, 1.6 kilometers. There are 2 toilets in 2 corners. You have no chance to get to the toilet if you need. You can see here the corridor, and here in the middle, there is a center that they built for me. There is a toilet, so you can make the toilet in my place, and you will not lose your pee-pee, as they say. Luckily enough, they respected our ideas, and they opened the first post-COVID outpatient clinic. As you can see here, it is named after me, and we are following there the post-COVID patients. So the post-COVID is a very interesting entity, which we knew this entity from EB virus, which is responsible for 33 different autoimmune diseases, or CMV, and even other bacteria, which can be followed by emergence of autoimmune diseases. And as you can see, there are many signs and symptoms. The signs and symptoms remind us very much the story of fibromyalgia, chronic fatigue syndrome, and also the silicone breast implants, and also CACU, which we have reported, and also other adjuvants, as you can see here. And these are some papers which appeared also in very neglected journals like Nature about, they call it long COVID, or you can call it post-COVID, and you can call it fibromyalgia, or as the new name, myalgic encephalomyelitis, following the COVID infections. The symptoms and signs which remain in these people, usually after 2 or 3 months, are all the signs and symptoms that you find in fibromyalgia. All the other symptoms disappear. This is a book that appeared this year, actually several months ago, that we have written about fibromyalgia. And fibromyalgia is a classical autoimmune disease. This is a paper, a seminal paper in JCI, Journal of Clinical Investigation, in which they have taken the blood from fibromyalgia women, by and large, 83%, injected it into mice, and the mice developed all the characteristics of pain, sensitivity to heat, etc., in the mice. So you could transfer the fibromyalgia clinical characteristic to mice via what? Via autoantibody. So which are the autoantibodies? There is a group in Germany headed by Gabriela Riemer-Kasten, who wrote a paper that was published also in Nature Communication about functional G protein. I was in their Congress, I even criticized them why they call it functional and not pathogenic, etc. It took me 11 times to read this paper and to understand it. they made a revolution. They revealed new autoantibodies that we have neglected in the past. These are autoantibodies against the autonomic nervous system. The regular nervous system, I put my finger on the nose. It's very well understood by me. I know that I have put the finger on the nose. But the autonomic nervous system consists of two arms, adrenergic and muscarinic, adrenaline and acetylcholine. And they have to be in balance. And what happens when you have these autoantibodies, you generate imbalance. This is our paper on silicone breast implants, which they have imbalance of the autonomic nervous system by specific 18 different autoantibodies to G proteins of the autonomic nervous system. Suddenly we have an explanation to the dry mouth, to the dry eyes, to the paresthesia, to the post-tachycardia syndrome, to the severe fatigue, etc. And we don't need to send these people to many MRIs and CTs, but we can actually send them for plasmapheresis. Here you can see our paper, which was published recently with all the signs and symptoms of similar to fibromyalgia. And these are the autoantibodies that we have reported to the autonomic nervous system. So we are not the first one. It was envisioned by a Mexican well-known researcher about the autonomic nervous system, functional autoantibodies that may explain all the features of the fibromyalgia. This is our paper, which is in Nature. It was not accepted to Nature. It is in Nature, in the building Nature. We hope it was sent for review. We hope that it will be accepted, analyzing these autoantibodies to the autonomic nervous system in the COVID syndrome. This is in collaboration with Gabriela Rimmerkasten and a guy from Brazil, very clever one, Otávio, who knows to do all the statistical analysis, which I cannot understand. And I hope that the researcher of Nature also will not understand and will accept the paper. This is his team of Otávio in Brazil that did this paper with us. As you can see, these are all the collaborators from United States, Germany, etc. So in a summary, I told you how we develop autoimmune disease. It's the hyperstimulation, the genetic characteristics, but also the environmental contribution. There is molecular mimicry, which is important to determine if you will develop multiple sclerosis, rheumatoid arthritis, or celiac disease, or whatsoever. I showed you that there are a group of diseases in which we have this hyperstimulation, but we, physicians, and even one Carlos, another Carlos, cannot explain the clinical presentation from severe fatigue to dry mouth, dry eyes, foggy presentation, memory loss, etc., like fibromyalgia, chronic fatigue syndrome, sick building syndrome, in which when you move from the building to another building, it disappears, following vaccine, following silicone breast implants, etc. All of them have in common autoimmunity to the autonomic nervous system. It's a new field. We will have to learn it, especially if our paper will be accepted to Nature. We couldn't achieve this revelation without collaboration. This is our Friday's meeting that I invite you. This collaboration is like in the picture near the Cappella Sistina in Rome, in which you can see Aristo, you can see Plato, you can see Pythagoras, which are sitting in the same field. This is the meeting that we are sitting here to discuss. And already I had some ideas with Yann de Moisier when I meet with him, with Carlos in his terrible car, in which I got immediately low back pain, but it stimulated my head, and with Antonio and Carlos Diaz, etc. So I thank you for your attention, and I hope to see all of you with new data in the Congress of Autoimmunity in Greece in June this year, in year 2022. Thank you very much for your silence and not keeping your eyes all the time in the telephone, because there is no information in telephone yet about this new autoantibody. Thank you very much for your.
Thank you, Yehuda. So questions from the audience? There's one just there.
Hello. About fibromyalgia, what do you think about the use of immunosuppressants or plasmapheresis, for instance?
Thank you for reminding me, because I forgot I wanted to say, but you know, I speak faster than I think. So I forgot this. There is a paper also from Germany, from Berlin, of a lady called Carmen Scheichenbogen, which means window looking, etc. And she published a paper in PLOS ONE of 10 patients with chronic fatigue syndrome who were plasmapheresed. 9 out of the 10 improved completely. I have the plasmapheresis serum, and I'm going to inject it into collaborative mice very soon, similar to the study that the people in JCI, very good paper, Journal of Clinical Investigation, showing that fibromyalgia autoantibodies induce the disease. This indicates that plasmapheresis may be a good, expensive therapy. I didn't want to slide over my time, but I had slide about therapy of the post-COVID.
Any more questions? I actually have one. This, again, talking about fibromyalgia and all this sort of blurred, not very well defined syndromes that you've just mentioned. I was trying to go the other way around, and instead of putting them all in the same basket, could it be that there are different types of so-called fibromyalgia-like syndromes? And the example that I would like to put to you has to do with Lyme's disease. Patients with Lyme's disease have been known to have, and this has been published in several papers, have been known to have a chronic fatigue syndrome after the infection. And actually, what was interesting is that most of the authors from those papers suggested that IVIG could be a good treatment for these patients. I do have to say, and this is completely an anecdotal report, out of, I don't know, probably 10 patients that we had with chronic fatigue syndrome that could be associated with known infections, 4 of them had to do with Lyme's disease, and we did treat them with IVIG, and they all eventually ended up having, or finished having, got cured from their fatigue syndrome. Again, an anecdotal report. This is completely anecdotal, but my point is, could it be that we actually, instead of putting all in the same basket, that we have, how should I put it, fibromyalgia or chronic fatigue syndrome type A and type B, some of them would actually be autoimmune in nature somehow, and the other ones probably won't.
You remind me, my wife, whatever I say, you want to say the opposite. So in any case, no, I want the opposite idea. Put all of them at the same basket. It's the same pathogenesis, the same pathogenetic functional autoantibodies, and it would be the same therapies, including plasmapheresis, IVIG, etc. In many of the patients that I was encountered in my life with chronic fatigue or fibromyalgia, always they were analyzed for Lyme disease. Many of them were reported that they had borderline positive, but they never came from an area where they could encounter the Lyme disease. So it's one of the false positive. One of the things that I believe it's called in England red herring, which deviate us from the idea, etc. And if Lyme disease can do it, it's because it's an adjuvant bacteria. The Lyme disease is very similar to TB. What is adjuvant? The Freund adjuvant is dead tuberculous bacteria. So it has a very strong hyper-stimulating effect. So you can put in this one basket, lime, but don't separate it. Let's analyze the functional autoantibody. Now there are 18. We didn't know yet which one is responsible. Actually, we know for the POTS, the post-orthostatic tachycardia, which is responsible for the hearing loss. You won't believe. We looked at the inner ear and we found receptors for autonomic nervous system. Many of the women with silicone implants complained that suddenly they had allergy to food, etc. And I said, how come? We find out mast cells have G receptors of autonomic nervous system. So the nervous system is all of our body, but we have neglected it. The neurologists have neglected it, and we, internists, immunologists, whatever, neglected it too. It's too complicated because we have two arms, etc. But now that we have the system to measure the autoantibodies, we have to learn them. We have a lot to learn. Jan, it should enter into the easy program. Which laboratory can do it? What is their function? Are they pathogenic, which we do by injecting them into mice? Who is related to hearing loss? Who is relating to sweating, which some women produce, and to the severe weakness? So plasmapheresis, IVIG, maybe progressive physical activity, like we do this chronic fatigue syndrome. Maybe homeopathy, maybe, I don't know. We have to learn. We are in a new area of autoimmunity, the autonomic autoimmunity, which we call dysautonomia. So it's not as simple as multiple sclerosis, as rheumatoid arthritis, etc. It's dysautonomia.
Right.
So a new field, a new area, new diseases, autoimmune.
Carlos.
Yeah,
I am vaccinated.
yeah, me too.
You are vaccinated.
Right.
Take
Yeah,
your mask because I cannot hear you. I
Yes,
read
I
lips.
understand.
Oh,
Of course. Thank you. So a new field of disease after immunodeficiency, autoimmunity, autoinflammatory. So I wonder why it didn't happen with the other coronavirus. Well, okay, you say the spike and so on. But do you believe that it's the autoantibody that that is the full responsible for the picture?
no. First of all, I believe in God. But what I believe in here, you mentioned immune deficiencies. This is another mechanism which it was mentioned in the big slide. You know, there are different ways to go to Rome, which I'm going this at 1 o'clock. But there are also many ways to get to Porto. Yesterday, I woke up at 2 o'clock in the morning to get here at 2 o'clock in the daytime. So immune deficiency has another thing of hyperstimulation. If you don't have IgA deficiency, which is very common, 1 out of 400, you have more penetration of bacteria and viruses, and therefore you have the hyperstimulation as a secondary effect to immune deficiency. As per the COVID, I want to characterize it very sharply. There is the destruction of the virus because of the ACE2 receptors. So the lung is very rich with the ACE2. We found that the ovaries and the testicles are very rich. Therefore, in 10 years, 15 years, not now, we will find many young women and young men who went through and they will be sterile. We will have an increase in IVF, in vitro fertilization. So there is the destruction of the lung, which we need the ECMO and we need this. This is a pathogenicity of the virus per se. The other effect of autoimmune is secondary to the hyperstimulation. For instance, you have destruction of cells. You have many nuclei and compounds from the cytoplasm spilled into the immune system, and then you develop anti-TNA, anti-mitochondrial, whatever ingredient is in the cytoplasm. This is a secondary effect. Therefore, for me, the post-COVID is more reasonable. The very quick effect of the COVID seems to be that it's very unusually hyperstimulating the immune system, very unusual. We have never seen it. You and I am older than you. I am your teacher, but I couldn't imagine that there is such a virus. You also couldn't imagine. Nobody could. Whatever I predicted about the virus, I was mistaken. Even today, I'm mistaken. So maybe all my lecture is mistaken. But if I will not raise the possibility, you will not analyze, and Jan will not bring it to the easy to challenge.
Okay, so we're about finishing this. Thank you very much, Yehuda. Thank you all, and I'll see you in the next session.
Good morning. Professor Sabino Siasia, we apologize for the delay. Good morning, everyone here. Thank you, Professor Carlos Vasconcelos and Dr. Carlos Dias for being here again in physical presence today. In this session, we will be pleased to hear Professor Sabino Siasia talk about tailored therapy in APS. Professor Sabino Siasia is Assistant Professor and Consultant at Multidisciplinary Center of Immunopathology and Rare Disease, Nephrology Division in the Department Clinical and Biologic Science from University of Turin, Italy. He is member of the steering committee of the Antiphospholipid Syndrome Alliance for Clinical Trials and International Networking, APS Action, and has a long experience in APS with thousands of publications in this field, contributing to the publication of national and international guidelines. Professor Sabino Siasia, thank you for accepting our invitation to speak about tailored therapy in APS. It is a pleasure to learn from your experience.
Thank you so much for such a nice presentation, and thank you again and again to the organizers. As they have been introduced, both Carlos, it's a big privilege for me to be and share some thoughts with you all. It's just a pity not to be physically with that, but I'm sure there will be other occasion in the future to visit again your wonderful city. So it's always challenging following Professor Shelfin in one of his lectures, because one can think what else I can add that has not been already said before. So what I'm going to try and to share with you is just some thoughts in how we can manage our patient with antiphospholipid syndrome, looking a little bit into the eyes of this patient. So we know that some facts. Antiphospholipid antibody syndrome is characterized by thrombosis. It is probably the most common acquired thrombophilia condition. And we know that also pregnancy morbidity is part of the picture. But what probably makes this syndrome so fascinating and so interesting for studying and for researching in this setting is the fact that antiphospholipid antibodies and the syndrome per se goes much beyond thrombosis and pregnancy morbidity alone. And we have a full spectrum, I would say a constellation of other signs and symptoms that are not purely thrombotic related, but they are often seen in our patient with this syndrome. We might have leg ulcers, we have thrombocytopenia, we have cytopenia in general, like hemolytic anemia, but we also have heart valve disease and so on. So we have a full spectrum that fully recognize the disease as an internal medicine disease. So the idea of treating in a more specific and tailored way this patient is very challenging. So when preparing this talk, I say how I can say that how I foresee therapy in this patient. So when we are looking for a patient to be attended with APS, things can go in different way. We can have a stable APS, a patient stable on anticoagulation who makes his life normally stable over the years. Unfortunately, sometimes things don't go this well and things get more complicated. Sometimes we have patients that refractory to the current treatment. Sometimes we have patients with more 1, 2, 3, or 4 events along their life. Some patients might have one thrombosis and then develop one of the so-called extra criteria manifestation. Or some other patient might develop at the beginning of their story some extra criteria manifestation without having the full-blown syndrome with thrombosis on pregnancy morbidity. And for the topic of this talk with you all, I would mainly focus on how we can tailor therapy in this setting, knowing that another great speaker in this meeting will tackle more the issue of anticoagulation and how we can improve the management of anticoagulation in this patient. When we have to think that how we can improve the therapy, I think that one way that we can look at the problem is looking back to the pathogenesis of the disease. And without going in too much into detail, mainly we can see that so far the information that we have is that the pathogenesis of the disease is complex. Is of course antiphospholipid antibodies related, but the way that these antibodies can relate to the development of the clinical symptoms might change. We might have an interaction with coagulation factors, platelets, endothelial cell, monocyte, and this is probably one of the pathway more studied in setting on the basis of the developing thrombosis. But there are more and more evidence that are supporting also other pathway, some of them complement related, and some of them complement independent, opening the pathway of new therapeutical tools to manage this syndrome. And starting with this in our mind, I will share some thoughts with you about some potential therapeutical option that might fit into the setting where anticoagulation is not enough. I will start with an old friend. I think that all internists and rheumatologists are super familiar with the hydroxychloroquine, and we love this medication because it's a perfect immunomodulant, is safe, has an acceptable safety profile, usually is not related with a lot of side effect. And we have now data proving that in both in vivo and in vitro models, hydroxychloroquine improves the procoagulant status, improves the vascular status. We have data from, for instance, lupus cohort that the use of hydroxychloroquine reduced the prothrombotic status. And also we have data supporting that the use of hydroxychloroquine might reduce the APL levels. So the point is that when using hydroxychloroquine in which patient? So should we use in all our patients? Should we use in all? In some? We still don't have solid evidence to answer this question. There are some rationale in using hydroxychloroquine in different settings. For instance, one could be considering use of hydroxychloroquine in APL carrier that is patient with no previous thrombotic event nor other non-autoimmune disease. We tried that with the APS action, the network that has been previously mentioned. The rationale is strong. Probably is one of those things that are hard to prove because we might need a big number of patients, sample size will be incredibly high to prove a reduction as primary thromboprophylactic agent. Of course, the rationale is strong, and for the same reason, sometimes we might consider to add hydroxychloroquine in those patients who are already stable on anticoagulation, but they might have a new event during the follow-up, the so-called refractory case. I think that one new potential intriguing indication for hydroxychloroquine comes from the pregnancy-related complication. In the past, we have reviewed a cohort of 170 pregnancies occurring in roughly 100 women with APL, with or without lupus, and we noticed that in a retrospective fashion, the use of hydroxychloroquine was associated overall with an improvement of pregnancy outcome, even when we split them in terms of live birth, overall pregnancy morbidity, and so on. And this evidence triggered, among others, the designing of different studies that are trying in a prospective randomized way to prove if truly adding hydroxychloroquine in women with APL might improve the overall pregnancy outcome. We have the BISCO studies, the BBQ studies, and the PATIA study that are currently ongoing, and probably in one of the next meetings in the future, we might have solid evidence if adding hydroxychloroquine might improve the prognosis of patients with obstetric IPS. Yet, one of the questions that might be still open in this setting is, among all the women with APL, who are those who might benefit the most of additional therapy at the top of the standard of care? And among the other studies, this is data coming from our center showing that if we take all the women that are going through pregnancy treated with the so-called standard of care, so aspirin, with or without heparin, according to the previous thrombotic or pregnancy morbidity status, we apply in this cohort of patients a scoring system that we developed a few years ago, the so-called global antiphospholipid score, which compute together the APL profile and cardiovascular risk factor. We noticed that higher was the score, higher was the risk for these women to have a poor pregnancy outcome. So this is just to trigger the idea that probably moving forward a tailoring approach, we should identify subgroup of patients among the patient with antiphospholipid antibodies who might benefit the most of specific strategies. And among others, in this case, the GAPS, the score, seems to be able to identify those who might benefit for adding on therapy. Moving to other old friends in immunorheumatology who might be used in this context, we can move to IVIG. We all know that IVIG are immunomodulator. Their use is supported in different cases of refractory. For instance, in a recent review by Anna Cohen and co-workers showing that even though on evidence, not in an evidence-based way, but more on the expert opinion fashion, the use of IVIG might be considered in patients with thrombocytopenia, especially when rituximab is failing. The evidence that we have so far is scattered in terms of the protocol used for using IVIG, but I personally feel that IVIG might be a useful tool, especially when patients develop one or more thrombosis despite well-conducted anticoagulation. And in line with this thought, recently an Italian group review on autoimmunity reviews the evidence that so far we have in this setting, and they collected few anecdotal cases, but also some study cohort, one coming from our group with 5 patients, and a subsequent one with a bigger cohort with 14 patients, showing that the prolonged use of IVIG, especially in those complex patients in which more thrombotic event may happen despite ongoing anticoagulation, might be a tool in this setting. Interesting, in one of these papers, also a reduction of the APL titer was mentioned. So this is also something that we should consider when adding IVIG at the top of anticoagulation in this patient. I mentioned when thinking about the pathogenesis complement And now the number of therapeutical tools, drugs that might target the complement is potentially increasing. We have still anecdotal data in this field when thinking about APS. The first data were following the introduction of eculizumab in the nephrological world. A few years ago, we collected the available evidence in which eculizumab was used to treat lupus nephritis. But among those patients with lupus nephritis, a few of them were also presenting with thrombotic microangiopathy, positive for antiphospholipid antibodies in line with the so-called APS nephropathy. And in this case, there were signals of potential efficacy of the use of eculizumab. Following that preliminary data, different studies has been supporting this evidence, again, on anecdotal fashion. And this is, for instance, one more recent study by Kello and co-workers showing that in patients with APS, especially in the multisystemic form of the syndrome with low platelets and the microvascular involvement, eculizumab seems to be a therapeutical option. And this is, these are the data that the Kello and co-worker showed, supporting an improvement in the, at least in the platelet levels in all the patients that have been treated with eculizumab, an improvement also on the renal profile. Of course, eculizumab can be considered a therapeutical option, especially in the refractory microvascular cases, but still some limit may exist. First of all, the cost of this medication, the availability for this medication, the possible risk for infection. It will be very interesting to see in the future how, with the number of anti-complement therapy increasing over the years, how this medication, and if this medication might take a place in the management of APS. But the idea of targeting the complement is definitely appealing, again, especially in those with microangiopathy thrombotic involvement. Moving to the other arm of the potential pathogenesis of APS, so moving towards the mTOR signaling, I'm confident that you all are aware of the paper in New England Journal by the French group supporting then in 2014 another addition pieces of the mosaic of antiphospholipid antibodies supporting that also the mTOR pathway might be a key player in the development of the syndrome, especially in the so-called APS vasculopathy. So not pure thrombotic events, much more in line with the disease of the vessel in a more systemic way. And Cano and co-workers show, taking a very peculiar cohort of patients with APL, that is those who receive transplant, they prove in a very elegant way in a study mixing both animal models, in vivo model, and a cohort of patients, that among the patients with thrombotic microangiopathy in the setting of transplant and having APL, those who receive sirolimus seems to have a better prognosis in terms of transplant when compared to those not receiving sirolimus, opening a possible pathway for the use of this medication. Again, one question still remains: who are the patients who might benefit the most of this treatment? And at the top of that, we have to consider that sirolimus is not a super manageable drug, sometimes can be associated, and there are reports also to a prothrombotic status associated to it. So again, we have to choose the candidate for this medication, balancing pros and cons. Moving to the last part of this consideration that I'm again grateful to be able to share with you, I would move to targeting what will be ideally probably the strongest rationale of moving forward beyond anticoagulation and the therapy of APS, which means targeting the antibodies. Because if we are considering that this syndrome is supported by the pathogenic role of antiphospholipid antibodies, ideally targeting the antibodies will be the missing point and the missing piece so far. Where are the evidence? Among others, one of the first studies supporting the use of targeting B cells with rituximab in that time, 2014, was coming from this phase 2 trial led by Doru Kerkan and co-worker in New York. They collected a cohort of patients with or without full-blown IPS, but all APL positive, with both criteria and extra criteria manifestation of the syndrome. And they found that rituximab can be a potential candidate, especially in some specific manifestation of the syndrome, especially in some of the so-called extra criteria. And these are, in brief, summarizing the data, showing that at least in the context of skin ulcer and cognitive dysfunction, the evidence in their cohort seems to be stronger. In other situations, like for instance in cardiac valve disease, rituximab did not seem in their hands to make a difference, and there was like a trend, if not even if has to be proven in other manifestations like thrombocytopenia and the APL nephropathy. So the story of moving the or targeting the B cells when considering APL from that trial, of course, moved on. And with new therapeutical option able to target B cells, more idea will come out. And this, for instance, another experience coming from our group, an anecdotal way in which in 3 patients, all with lupus, but all with IPL positive, the treatment with belimumab, the anti-BAFF monoclonal antibodies, was associated with a reduction of the titer of the APL. Interestingly enough, in 2 of the patients in which the belimumab was suspended, in one case because the patient was planning a pregnancy and she didn't want to use a monoclonal antibody during at that time, and in the other cases in which the patient was very stable with his disease, so we decided to suspend the belimumab. In both of the cases, after when belimumab was stopped, the antibodies came back. So this was a nice proof of concept, proving that probably targeting the BAFF system could be a therapeutical option, with the idea in mind that lower the antibodies, lower the risk of having thrombotic complication. These data were then confirmed in larger cohort, and this is, for instance, a study by Giacomo Emmi and co-workers showing that not just belimumab can reduce the APL antibodies, but belimumab added to hydroxychloroquine might have a synergic effect in this setting. And this experience, when they're confirmed in a larger post-hoc analysis, when we took together all the data of the BLISS trial, belimumab in lupus, and we tried to assess if patient receiving belimumab has a change, a more significant change in their antibody profile during the follow-up when compared to those who did not receive belimumab, those patients in the control arm. And indeed, also in this setting, when putting together hundreds of patients, we observe a reduction of the antibodies in the setting of those patients receiving belimumab. So this information, when they're confirmed of other case reports, and this is another one, for instance, from Autoimmunity Review, showing that in the setting of a patient with not controlled anticoagulation because of very fluctuant INR, heart valve disease, the use of belimumab was not just associated with a reduction of the APL titer, but was also associated with the stabilization of the ANR and an improvement in the valve disease. So all this data, still anecdotal, push us to try to assess if truly targeting BAFF with belimumab could be a therapeutical option in this setting. And this is a trial that we just starting now, and probably again results will come soon. So if adding belimumab in refractory patient or patient with extra criteria manifestation might have a role in the management of patients with antiphospholipid syndrome. Just few other words when we are thinking about targeting the antibodies, the literature, and in this case, the hematological world are providing us with new information, especially when targeting not B cell anymore, but plasma cell. And this is, for instance, the experience from multiple myeloma, then driven also in the field of lupus with the use of daratumumab. I'm sure that you are aware about this report in the New England Journal of Medicine when the efficacy of the potential efficacy of the daratumumab was proven and shown in some patients with lupus refractory to previous treatment. Again, we know that sometimes APS reproduce stories of other diseases. When we have a medication that works in lupus, oftentimes we think that this can happen also in antiphospholipid syndrome. And this is one recent report showing that anti-CD38 monoclonal antibodies therapy with daratumumab might be a potential candidate also in the field of APS. Again, daratumumab is a very potent monoclonal antibody. So again, when thinking of which patient might benefit the most of this therapy, again, we are moving the field of refractory patient or patient with multi-organ involvement. Going back again to our experience in Torino, we are starting to use more and more daratumumab in the field of autoimmunity. And these are the characteristics of 5 patients with lupus nephritis, refractory to rituximab or standard therapy, in which we are currently using daratumumab with the coping, the multiple myeloma protocol. So infusion 1 to 8 on a weekly base, then move it to every 2 weeks, and then a monthly infusion. So it's a prolonged immunosuppressant therapy. I don't want to give details on the efficacy on lupus nephritis, but I just want to share the story of this patient. That was the first patient that we started to treat. Apart from an improvement in terms of the level of proteinuria that was in the nephrotic range at the beginning, and improvement in the SLEDAI, what we were surprised to see, it was also a marked reduction of the APL during the follow-up. And these are results in 9 months. Of course, this is still too early to say if daratumumab will really play a role also in the APS. But again, the reduction of antibodies in this setting is very intriguing when considering very severe cases in which anticoagulation might not be enough. So summing up, I think that things are moving on from considering APS just a thrombotic disease. And in line with this comment, the therapeutical option that we are having are increasing so far. When thinking which is the patient who might benefit the most of a specific therapy, I think that the combination of keeping in mind the pathogenesis of the disease and the clinical setting might be the key. And this will fit with the use of hydroxychloroquine, as we mentioned, or maybe using the more complement-mediated strategies, especially in the setting of thrombotic microangiopathy. But a lot of the story will be still to be told. mTOR inhibitors, the role of anti-B cells, of anti-plasma cell, and the use of immunoglobulin. I think that the real challenge for the future is, again, moving beyond the classification criteria and try to understand if among all the patients with APS and among all the patients with antiphospholipid syndrome, the full-blown syndrome, different clusters exist. Because if we would recognize different clusters, this is where therapy will really be tailored for the specific patient. So I want to conclude with a hope, this talk, hoping that in one of the next future, we will move from the idea that the only biomarker that we have in the syndrome are antiphospholipid antibodies, but potentially in the future we'll have more biomarkers, making us able to identify those patients who will be stable over the year with these antibodies and no more problem, or those patients, on the contrary, with a more severe profile in which we would have the need for more aggressive treatment. And with this, I thank you all.
Thank you, Professor. Are there any questions you want to ask?
Hello, good morning. Thank you very much for your talk. José Alves from Amadora. My question regards we've been talking about this over and over again, about the importance of controlling antibody titers and addressing and the potential use of targeting the antibody titers as a way of treating APS. Now, most of those studies, in fact, as far as I can remember, all of the studies have showed benefits from these kind of therapies, always in the non-classification criteria manifestations. Now, I believe this just deceives completely the point, because one of the reasons why we define these criteria and why we do not consider them in the classification is that these criteria are not in themselves able to differentiate APS from other diseases. So if we have a drug that only treats the criteria that are not specific for APS, we're just treating whatever else the patient has. And this is the first part. The second part has to do with the fact that one of the reasons why we can't do primary prophylaxis studies, as you mentioned, is because you would have to have a huge population. And the reason why that is because there's thousands, eventually hundreds of thousands of people that are APS positive in some ways, and they do not develop the syndrome at all. So you couldn't guess, which again makes the point that if we're controlling the antibodies, and if most of the people that are antibody positive do not have the disease, we're definitely targeting other condition rather than the APS. I understand this is a problem and we need to treat the patients, so we need to give them as much as we can. Because again, when you're treating with anti-plasmacyte drugs, well, you would expect the antibodies to go down. You're just killing the cells that produce antibodies, so they will all go down. That doesn't mean that the patients won't still have thrombosis. So what are your comments on this?
So that's a very good point. This is why I started the presentation, say that most of the information that I was to share was to consider either refractory cases or extra criteria manifestation, because I completely agree. I think that the bigger problem is that we still mix different patients with different profile under the same umbrella, calling all of them APS. So I completely agree with that. Another point to increase the level of complication in that is one of the diseases in which even when we start a clinical trial, we don't know what to measure. We don't have an activity index, for instance. We don't have anything that beyond the recurrence of the event. And this makes things even more complicated. So the idea behind what I was trying to share with you is the idea that so far, probably the most that we can do is going back to treating the clinical manifestation. So I follow completely your point. Going to the idea of reducing the antibodies, this will be, the rationale might be there. It's true that on one side, we don't know if if once we target the antibodies become negative, the patient won't clot again. And this is why we need more data. On the other point, I think that the future will open also to going not just in the idea of antibody specificity, but also moving among the same antibodies, for instance, in different pathway like post-translational modification, glycosylation, for instance, because this will add tools in saying why patient with the same antibodies, some of them will develop the disease and some won't. So I think that all your comments are completely summarizing the challenging that we are all facing when doing research in this setting.
Hello, Sabino. Thank you very much, Carlos. Very, very clear presentation as usual. Tell me, maybe I missed it. Are you checking regularly the titers of antiphospholipid antibodies? And second, if they become negative, will you stop the anticoagulation?
Thank you for the question. Usually, in clinical practice, which outside research protocol, we don't check the level of antibodies more often than once every 1 year, 18 months. So this is usually unless something change in the patient, like pregnancy or a new event. When going back to when antibodies turn negative, we recently reviewed our cohort of patients, and we saw that less than 8% of the stable patients with APS over the years turn negative. This happens usually in a meantime longer than 5 years. And at least in our cohort, all the patients who turn negative were those in which only a single positivity was identified at the beginning of the diagnosis. So we have seen patients getting negative. We have seen a very small amount of that. What to do in this patient? Usually we test also with the so-called extra criteria antibodies. For instance, we had testing for antiphosphotidylserine prothrombin antibodies. And if anything, and if everything comes back negative, and there are no additional cardiovascular risk factor, we consider to stop anticoagulation. If the extra criteria antibodies are positive, or if there are persistent cardiovascular risk factor, we consider to keep those patients on anticoagulation. But again, we have seen, at least in our cohort, anecdotal cases, and usually we're just low risk profile.
Hi, Savino. It's Yehuda Schenfeld, missing you here. I don't know why didn't you come. You don't like Via Dolorosa, but be it as it may, I enjoyed your talk. I want just to mention that we moved from dealing with the thrombosis to dealing, or hypercoagulation, to dealing with the antibodies, and you mentioned all the possibilities. I want to throw light also on why the antibodies are generated. And just to remind that we can use, especially in lupus patients, a very, very, very expensive drug and recommend vitamin D to reduce, you mentioned the hydroxychloroquine, but also vitamin D to prevent the production of the autoantibodies, just to say this. And best regards from Porto, beautiful Porto.
Thank you. Thank you for your comment, Professor Schenfeld.
Is there any question? Yes,
Ciao Savino, it's Laurent. It was an amazing talk as always. I have a question for you, which is very much related to the two comments we've had before. In primary antiphospholipid syndrome, we do not use immunosuppressive agents, but when it's secondary, and I'm thinking lupus, we can use immunosuppressive agents. In that situation, you can see the levels of the antibody decreasing, so APL levels going down. My question is, when we stop these anti-immunosuppressive treatments because we are not going on with them forever, what's going to happen with the title of the APL? Are they going up? And is this the proper direction to go? Because this will be only temporary suppression of these APL. If they reappear after we leave the treatments, then the risk may restore.
Hi, Laurent. As usual, sharp question. I agree. And this is why, again, I stress that I'm not considering targeting the antibodies in those patients who are stable over the year. But I think that my idea is to target antibodies where in those patients in which things are not stable and we feel that we need to add something. The personal experience that we are gaining so far is that when we have a group of patients, for instance, that has been treated with rituximab because of thrombocytopenia, some of like 20% of them, the antibodies got negative and stay negative. The majority of them, the antibodies came back in a time between 6 to 12 months, which was paralleling the B cells repopulation. Even though the antibodies came back, none of them have recurrences of the disease. On the secondary, on the second point, the experience with belimumab is more limited when compared to rituximab. The cases that I was showing you was confirming your impression that once we stop the treatment, the antibodies might go up again. The idea might be there is to bridge those time in the history of a patient in which things are getting more complicated, for instance, a recurrent event or a multi-organ involvement, and then monitor as we do in the other connective tissue disease. As you mentioned, we don't keep on going the immunosuppression in a lupus forever. So I don't foresee that we will do in the APS, but probably for a limited amount of time, targeting the antibodies or immunomodulating those patients might be an option.
Can I just ask you to confirm that when you said treatment with rituximab, then the antibodies went up and there was no thrombosis, that the patients were still anticoagulated?
Yeah.
Okay, thank you.
So there is any questions? So thank you. Thank you, Professor Sabino.
Thank you so much. Thank you all.
Good morning to everybody. It's for me a great pleasure to be with all of you. First of all, thank you, Carlos Vasconcelos and Carlos Diaz, for giving me one more opportunity to be here. And I have the great pleasure to introduce you, Renaud Felten. Renaud Felten comes from Strasbourg. He works with Laurent Renaud, already everybody knows him. And Renaud works in the Center of Autoimmune Diseases of the Hospital of Haute-Pierre. And his main interests are the multisystemic diseases like lupus, Sjogren, and the difficult diagnosis and the complex situations. He is a rheumatologist and a good clinician. And he writes something about, for example, salt like lupus, and the mixed connectivity chart. It's a mix of psoriatic arthritis and gout. It explains with a very interesting form in the recent article he published. It's very good to write and to hear from him talk about this. And interested for the main pathways, the complex pathways, the groups of pathways in pathogenesis, and array, not multisystemic, but with several aspects of multisystemic. It's very interesting here from him too. Thank you. Let's start, please.
Thank you. Thank you very much for the kind introduction, and thank you for inviting me here in Porto, first time in Porto. So it's a great pleasure to be here to talk with you about the tailored therapy in rheumatoid arthritis. Here are my disclosures. So you all may be aware about the last recommendation about the management of rheumatoid arthritis by the EULAR, published 2 years ago, in which we started we start with CS demand, methotrexate, and then we have to choose one targeted therapy, one biologic, or one JAK inhibitors. But the key question is, how should we choose one targeted therapy over another? So I will focus on two positions, the first line of targeted therapy and the second line. The most robust data that we have is the head-to-head trials in RA. There are only 9 head-to-head trials. Some of them are targeted patients with inadequate response of methotrexate, and one of them is in patient with inadequate response to anti-TNF, the select choice study. 2 of them, the ADAPTA and the Monarch study, are studying tocilizumab and sarilumab without methotrexate background therapy. So I will focus on the 6 other study, which compared some treatment and adalimumab on a background methotrexate therapy. So briefly, the HAMPL study compared abatacept to adalimumab in patients with inadequate response of methotrexate. It's a randomized controlled trial, and the results are presented here. There was no difference between abatacept and adalimumab on ACR 20, 50, or 70 response, or in the decrease in DAS28 score. So abatacept confirmed its non-inferiority compared to adalimumab on a background methotrexate therapy. The second one is the Accelerate study, which compared certolizumab and adalimumab in methotrexate inadequate response patients. The results are presented here, and certolizumab failed to show a superiority against adalimumab, but it's quite similar in terms of results on the different score. The third one is the oral strategy one, comparing tofacitinib and adalimumab, and the results are presented here. You can see that tofacitinib monotherapy is not so good, but tofacitinib on methotrexate is comparable with adalimumab and methotrexate. So tofacitinib showed a non-inferiority to adalimumab in combination with methotrexate in that study. The fourth one is the baricitinib one, the HERA-BEAM study, comparing baricitinib and adalimumab with a superiority of baricitinib over adalimumab with a background of methotrexate therapy. The fifth one, the select compare one, upadacitinib versus adalimumab. And again, there is a superiority of upadacitinib over adalimumab on the background methotrexate therapy. And the last of the 6 is the filgotinib one, the Finch 1 study, comparing filgotinib against adalimumab with a non-superiority but a non-inferiority study, showing a non-inferiority of filgotinib compared to adalimumab. So this is the summary of the results. And overall, upadacitinib plus methotrexate is superior to adalimumab plus methotrexate. Baricitinib plus methotrexate is superior to adalimumab plus methotrexate, and adalimumab, abatacept, tofacitinib, and filgotinib are non-inferior, and certolizumab has failed to show a superiority, but the results were similar in terms of score. As a second line of targeted therapy, there is only one head-to-head study, the select choice one, comparing upadacitinib versus abatacept on a methotrexate background therapy. It has been published this year in the New England Journal of Medicine. And you can see here that oral upadacitinib has been compared to IV abatacept with a primary endpoint, the mean decrease in DAS28 CRP at the week 12, which was greater in upadacitinib group versus abatacept ones. Here are the main results. You can see a decrease in DAS28 in patient achieving low disease activity and in ACR 20, 50, and 70 response that were greater in upadacitinib arms than abatacept 1. But there were some concerns about tolerance and safety in that trial, with more serious adverse events in the upadacitinib arm versus abatacept 1, more serious infection. So the conclusion was that upadacitinib was superior in this trial, but associated with more serious adverse events. When we have to choose one treatment over another, we can do indirect comparison, but there are several biases, so it's difficult for us to choose with only this indirect comparison. So we have to make other comparison, and there are 3 studies I want to show you. The first one was published 6 years ago, comparing after a failure of TNF inhibitors, abatacept or rituximab or another TNF inhibitor. They managed to include 80 patients, 22 with abatacept, 34 with rituximab, and 24 with TNF inhibitor. But the results were quite similar in that group. The second one is a VARIA study comparing rituximab and a second TNF inhibitors after a first failure of TNF inhibitor. And the result was the same, with no difference between the 2 groups, second TNF inhibitor or rituximab. And the third one is the rotation or change trial, which has been conducted in France by Professor Gothenberg, my mentor in Strasbourg, a 52 weeks multi-center academic, pragmatic, open-label, randomized control trial, which assessed in patients with a first failure of an anti-TNF, a TNF inhibitor, a second one, or another mode of action. The primary outcome was the EULAR good or moderate response at 6 months. So if a patient had a first anti-TNF with a fusion receptor, it received a monoclonal antibody. If he had a monoclonal antibody, it received a fusion receptor. If he was randomized in the rotation arm, and in the changing arm, he received another mode of action, either IL-6 receptor inhibitor, rituximab, or abatacept. In that trial, we managed to include 300 patients. And here are the results of the primary outcome. You can see here that patients who were changing of mode of action had greater response than a patient with a second anti-TNF inhibitor. It was the same in terms of retention rate, with a greater retention rate with a non-TNF targeted biologic. And of note, in an interesting way, we have tried to explain this difference, and we have managed to show that in patients developing anti-drugs antibody in green here, 11 patients developed anti-drug antibody after their first anti-TNF inhibitor. The 11 patients had a greater response than the patient who did not have anti-drug antibody. And when we compared these 11 patients starting a second anti-TNF, but who failed their first one because of anti-drug antibody, the results were comparable with the patient who changed the mode of action of the second targeted biologic. So the conclusion is, after a failure of a first anti-TNF, changing mode of action is better than a second anti-TNF, except in case of anti-drug antibodies. So is there any other selection criteria? Yes, of course, there are. Here are some example of selection criteria driven by patient, physician, or itself. If you are faced a young woman, you would prefer certolizumab, or in young patient, you would prefer monthly injection or oral drug. In terms of disease activity, if you are faced a high inflammatory syndrome, you would prefer anti-IL-6 receptor. If there are some drugs which are associated in patient treatments, you would avoid baricitinib if there are some interaction, or tofacitinib because of drug interaction. If you can anticipate compliance issue, you would prefer IV therapy for better follow-up. And you would prefer some treatment over another for habits or preference or personal beliefs. In terms of comorbidities, there are also some selection criteria that can be take into account. In case of a recent neoplasia, you would prefer rituximab. In case of hypogammaglobulinemia, you would avoid rituximab. In a case of high tuberculosis risk, we would prefer etanercept, abatacept, or rituximab. In case of diverticulitis, we would prefer to avoid anti-IL-6 receptor nor JAK. In case of a history of high risk of venous thromboembolic or pulmonary embolism, we would avoid JAK. And in case of high risk of COVID-19 or non-vaccinated patient, we would avoid rituximab because of a higher risk of severe COVID-19 in that population and higher non-response of vaccination in that population too. Is there any other predictive response factors? Yeah, at least two of them are worthwhile. The first one is monotherapy. If methotrexate is not acceptable in one patient, you would prefer to give tocilizumab or sarilumab as a monotherapy, as they have shown their superiority in that case against adalimumab in two trials, the ADACTA and MONARCH studies. The second one is the status of the seropositivity. And you can see here the results of the SERARA registry, which assess the mean change in DAS28 in case of seropositive or seronegative patient treated by rituximab. And you can see here that rituximab is work better when patients are seropositive than when they are seronegative. It's the same for abatacept in the PAN-ABA registry. You can see here that we have greater results when patients are seropositive and a greater retention rate when patients are seropositive. So in seronegative patients, abatacept and rituximab are less effective than in seropositive ones. And what could be considered in the future? This is a quite old paper published 7 years ago by Dennis and collaborators, which aimed to assess if there are some patterns in synovial biopsies. And they managed to show 4 different patterns: the lymphoid ones, myeloid, low inflammatory ones, and the fibroid one. And they managed to correlate some serum biomarkers with these patterns in the choice of a biologic. And you can see here that the serum biomarkers, the HICAM1 and the CXCL13 can predict the response to adalimumab or tocilizumab. More recently, was published in the Lancet journal, the first biopsy-driven randomized control trials assessing rituximab versus tocilizumab in the R4 array trial. Patients were biopsied at baseline and were classified histological as B-cell poor or B-cell rich patients, and then were randomly assigned to receive rituximab or tocilizumab by intravenous. And then to enhance accuracy of the stratification of B-cell rich or B-cell poor patients, they also were classified according to RNA sequencing molecular signature. The primary endpoint was defined as a decline in the CDAI of 50%. Yeah, as a result of the patient with a B-cell poor population, you can see here that there was no difference between groups according to histological classification in that patient. But when considering RNA sequencing classification, there is a higher decrease in the CDAI in patient, a higher proportion of patients reaching the primary outcome in the tocilizumab treated population than in the rituximab one. And it was the same when considering more robust or more stringent endpoints with a CDAI decrease of 50% and a CDAI below 10 points at week 16. So the primary endpoint of this study was not met, but tocilizumab was superior to rituximab in patients with low disease activity and a B-cell poor population, and more robust results by RNA sequencing than histological classification has been raised. So as a conclusion, the tailored therapies in RA relies on a few H2H trial providing valuable data, but not so much trials. Relies on comorbidities, on disease itself. Are patients seropositive or not? Have they extra articular manifestation or not? It relies on patient and physician preferences and pragmatic trials. And in the near future, maybe cyanoval biopsy or RNA sequencing driven therapy could help us. Thank you very much.
Thank you, Renaud, for your nice talking, focusing the several, almost all the topics important in clinical practice. Somebody have some questions to Renaud Felten? Carlos?
Thank you, Renaud. Very clear presentation also. Probably I should know that, but what is the explanation for this higher response in those that have anti-TNF antibodies? In those patients that have a previous anti-TNF, and then you choose a second one if they have antibodies.
Yeah, it's a great question. Why should a patient receive the second anti-TNF after a first failure of a first one? And some patients did respond. So it's a great question. Maybe it's due to some differences between TNF inhibitors, or maybe it's a difficult question because I don't know what to say, but yeah. No, it's no. The question is about the anti-drug antibody. If the first failure is due to an anti-drug antibody, for instance, adalimumab with anti-adalimumab antibodies, then you can choose etanercept or certolizumab, and it will work as well as another mode of action. No role, no cross-reaction. No, we see. Yeah.
Can I just make a comment on this? In your study, if patients did not respond to an anti-TNF, you would use a fusion molecule, which means that if those anti-drug antibodies were anti-FC, they would not link to the second drug.
Yeah.
And that is probably the reason.
Yeah.
You were taking the FC region, so it wouldn't be there.
Yeah, probably. Only in 11
Not to
patients.
mention that some of the anti-infliximab ones would be transient. So you need to know what kind of anti-drugs antibodies are to make sure that.
Yeah. It was a post-hoc analysis.
More questions? I think I have one. In the first part of your talking, you show us several head-to-head studies.
Yeah.
And we know that Bari and upadacitinib were superior than the others. But curiously, Filgo was not. What do you think about the more or less specificity of the different inhibitors of JAK?
Yeah, it's a great question. The question is there a class effect of JAK inhibitors, or are there any differences between JAK inhibitors? I think there are some differences, and then we'll show you some differences in my second talk. But in fact, for the anti-TNF, the efficacy is the same for all the anti-TNF. It's not the same for all JAK inhibitors. So filgotinib should be a little bit less effective than baricitinib or upadacitinib, maybe.
Sorry, it's me again. It's becoming more and more common in EULAR and when we talk about treat to target to address the head-to-head studies. As far as I can see, this has a huge methodologic problem, and that is, if you're tailoring therapy, you should not be comparing drugs. You should be comparing drugs in patients. What I'm trying to say is, if for a second choice, you're comparing rituximab versus whatever, or drug A versus drug B, and if you're not discriminating the group of patients, then the only thing that you're saying is that one drug is better than the other. You're not saying anything in relation to that particular kind of patient. So this is a methodological, as far as I can see, error in the way we are approaching this. Either we choose treat to target, which is a clinical addressed issue, or we're talking about tailored therapy. If we're talking about tailored therapy, we should not be comparing drugs. We should be comparing drugs in the context of the group of patients. For instance, rheumatoid factor positive versus negative with rituximab. That means that if it's positive, should be that. Because this raises a very important issue, and that is you're getting to the conclusion that not you, I mean, the world, of course, you're just a messenger, and we don't kill messengers yet. But the point, hello, Laura. The point is, you're saying, I mean, the studies are suggesting that, for instance, tocilizumab could be a better choice than, or drug A could be a better choice than drug B as a second therapy after refractory patients or non-responders or whatever. Well, that doesn't mean whether that drug should be the first choice in the first place. So what we need to look is head-to-head is great if all the patients were the same. They are actually not. So we need to decide what methods are we using to answer what questions. And tailor-made does not get answered with head-to-head. That's what I think.
Yeah, I totally agree with you. That's why I have not only presented a head-to-head study, but other mode of study and other mode of choice for tailored therapy. I agree with you that the inclusion criteria and exclusion criteria of actually are very important to make a decision and to avoid some global conclusion in the area population, because it's not the case.
Sorry, I just want to make a post comment because this is the I don't know how it works in France, but in Portugal they have this problem with nursing hospital whereby you're going to decide for the second drug and they will say, oh, for the second drug, this is better than that. Yes, but that's not the point. In patient A,
Yeah.
that doesn't apply. So if you're generalizing, I don't know whether in France you have liberty to order to change. That is becoming very complicated.
Thank you, Renaud.
Hello.
Thank you for nice talking, for your work, and thank you for coming.
Welcome back. Now it's a session sponsored by Novartis, and I'm trying. So I thank Novartis for inviting me for sharing this session about still disease. Still disease is a rare, not frequent disease, as you know. A lot of inflammation. I remember the patient that is well followed with a still disease, and we went always delayed in relation to the disease in the patient. And we, at that time, 15 years ago, we changed what we can about immunosuppressors, but the patient almost destroyed every joint. So they are rare diseases, and we have the adult, we have the pediatric, we have two subsets as it comes to our mind immediately, the systemic and a chronic one. And of course, we have to ask if it is the same disease. Shall we treat the same way? Which treatments do we have in this new era of biologicals? What about the hypothesis? Is it that the hyperferritinemia hypothesis, a very nice hypothesis that put together HLH syndrome, hemophagocytic, catastrophic APS, is it really a disease related to ferritin and low glycosylation, low ferritin, low glycosylated? So, and trials are very difficult to obtain because the recruitment is very difficult. So we have a lot of questions in this rare and very, very stimulating disease for physicians, but not for patients. And we have the pleasure to have two speakers, Professor Iva Brito, and we will start, I think, we'll start with Professora Iva Brito, é uma reumatologista dedicada fundamentalmente à pediatria, passou a vidinha dela toda no Hospital de São João, não quis mudar do hospital. Yeah, sorry, I changed to Portuguese because Professor Iva Brito will speak in Portuguese, but the slides will be in English. Professor Iva Brito, thank you very much.
Então, muito bom dia a todos. É com imenso prazer que eu estou aqui neste vosso congresso e espero contribuir de alguma forma para ser aqui algumas considerações acerca desta patologia, que é muito mais frequente, de facto, em idade pediátrica do que no adulto. No adulto é muito rara, mas aparece, obviamente. E vou começar por, então, eu sou reumatologista, mas dediquei-me desde muito cedo a esta área da reumatologia pediátrica, que é uma área de facto desafiante, difícil, e em que a maior parte das vezes nós temos que tratar os meninos, temos que tratar tudo aquilo que rodeia os meninos, que são os pais e a família, e isso muitas vezes traz-nos um desafio um bocadinho até angustiante na altura de decidir muitas vezes até as terapêuticas que vamos preconizar. Relativamente à artrite idiopática juvenil, eu começo aqui por dizer que a doença de Still tem esta designação de facto no adulto, mas não tem esta designação na criança. Já teve anteriormente, mas neste momento nós dizemos que a artrite idiopática juvenil comporta também a artrite idiopática juvenil sistémica, que, como vão ver, está em fase de revisão de critérios. E o que é que nós entendemos por artrite idiopática de juvenil? É um grupo muito heterogéneo, é um guarda-chuva de patologias, em que habitualmente temos que ter uma artrite objetivável, nós temos que olhar para a articulação e temos que ver que ela está tumefacta, está inflamada, portanto tem sinais inflamatórios, tem que durar pelo menos 6 semanas e tem que ter uma etiologia desconhecida e a idade será até os 16 anos de idade, embora agora nos critérios de diagnóstico que vão ser, aliás de classificação que estão a ser validados, vá até os 18 anos de idade, porque a faixa etária pediátrica aumentou bastante em termos cronológicos. Como veem, é uma classificação que tem sido alvo de muita controvérsia e de muita mudança e tem passado por vários critérios, várias designações em termos de classificação de doença. Como veem, em 1997 o ACR tinha uma classificação, depois o EULAR tinha outro e o ILAR, que é aquela que nós adotamos atualmente, tem outra classificação. Em que é que se baseia esta classificação? É no número de articulações envolvidas nos primeiros 6 meses de doença, a ausência ou presença de manifestações sistémicas e depois a presença de autoanticorpos ou de serologia reumatoides positivas ou negativas. Claro que isto é um bocadinho confuso, porque há muitas patologias que nos ficam por classificar porque não cumprem critérios de classificação, que são um pouco diferentes, como sabem, de critérios de diagnóstico. E então é uma patologia bastante prevalente, uma para 4 crianças em 1000. A oligoarticular, que é aquela que tem até 4 articulações atingidas, é de facto a mais frequente e a mais benigna. Há aqui uma forma um subtipo de doença, que é sobretudo em meninos pequeninos, com anticorpos antinucleares positivos e que incorrem em risco de inflamação ocular grave, são essas uveites que no fundo fazem com que o prognóstico seja mais severo. E depois a forma sistémica, que é aquela que nós vamos aqui falar, é variável na literatura, mas em média será 10 a 20% de todas estas artrites idiopáticas juvenis. Todas as outras depois têm conotação também com a do adulto, exceto a oligoarticular ana-positiva. A forma sistémica é, como eu disse, mais rara, 10 a 20%. A incidência está estimada em 0,0408 por 100 mil crianças e a idade de início mais habitual, o pico de incidência, será entre 1 e os 5 anos de idade e, curiosamente, ao contrário das outras patologias, é mais frequente, a frequência é igual nos 2 sexos, enquanto que na outra, muitas vezes, a frequência, como em quase todas as doenças imunomediadas, é no sexo feminino. Estes são os critérios que agora estão propostos pela Printo, que, portanto, é uma organização de trabalhos de investigação na área da reumatologia pediátrica, que também pertenço, e isto são os critérios adotados atualmente para nós fazermos o diagnóstico de uma artrite idiopática sistémica. Portanto, a febre de origem desconhecida, portanto, é uma febre cotidiana, isto é, tem que haver pelo menos diariamente, nem que seja 3 dias seguidos, mas tem que haver uma febre cotidiana, que habitualmente tem um pico vespertino, mas também pode ter uma febre matinal, e que tem que pelo menos persistir durante 15 dias, é um síndrome febril determinado. E depois terá que ter 2 critérios major, ou um major e um minor, como estão aqui especificados, sendo que o critério major é o rash evanescente, que é um rash salmonado, que habitualmente interessa o tronco, as raízes dos membros, e que varia conforme a febre, portanto ele habitualmente não é fixo, é evanescente, vai e vem, e tem um pico na altura febril, artrite e depois aqueles critérios menores que estão ali explicitados, sendo que a leucocitose habitualmente é superior a 15 mil, mais do que na doença de estilo do adulto, e habitualmente a linfadenopatia é superior até à presença de hepatomegalia e pode haver cirrosite. O que é que difere aqui estes critérios de classificação que estão propostos, mas não estão validados, daqueles que nós utilizamos atualmente como validação? É a obrigatoriedade da presença de artrite. Portanto, a obrigatoriedade de presença de artrite para o diagnóstico da sistémica traz-nos muitos problemas, porque habitualmente a artrite não existe logo no início da doença, pode demorar muito tempo a aparecer e muitas vezes aparece muito tardiamente, e as artralgias só por si, nos critérios adotados atualmente, não servem como critério diagnóstico, mesmo sendo artralgias inflamatórias. Aqui só para verem mais ou menos a classificação que nós temos então para as artrites sistémicas e quais são os critérios que vocês todos conhecem de Imagoshi para a doença de Steele do adulto, e veem que na doença de Steele, de facto, não é preciso a presença de artrite, não é necessária. Habitualmente a leucocitose é menor que na criança e o adulto reporta muitas vezes uma coisa que nós na criança não vemos, que é a odinofagia. Só esporadicamente é que nós nos apercebemos de que há. Claro que, depois de revermos a literatura e daquilo que está escrito, só 30% das crianças, nos critérios hilares, é que cumprem critérios de classificação de artrite idiopática juvenil sistémica e, portanto, isso para nós é um entrave na abordagem diagnóstica precoce destes doentes. Estudos recentes também mostram-nos que, isto é que é extremamente importante, é que a artrite idiopática juvenil sistémica é completamente diferente de todos os outros subtipos de artrite juvenil. Isto é uma doença de facto muito mais inflamatória, em que as manifestações sistémicas de facto são preponderantes. E verificamos que com os avanços nos dados imunológicos e na abordagem genética destas doenças, o que é que nós verificamos é que aquilo que está de facto, que é implícito à patogénese desta artrite sistémica é a imunidade inata e não a imunidade adaptativa como nas outras doenças autoimunes. E então nós conseguimos perceber que a artrite sistémica no fundo é o que se correlaciona, digamos, é a irmã gêmea da artrite, da doença de Steele do adulto. E, portanto, nós hoje em dia tratamos esta doença como sendo uma doença autoinflamatória poligénica, porque depois temos as outras doenças, como sabem, autoinflamatórias monogénicas, que são hereditárias, que são maiores. Portanto, o curso desta doença é muito variável também. 40% dos doentes com artrite idiopática juvenil sistémica podem ter um curso monofásico, isto é, são crianças que estão doentes, que têm manifestações sistémicas exuberantes, manifestações articulares, mas que entram em remissão, muitas vezes até com terapêutica mínor, entram em remissão passado algum tempo, são 40% dos doentes. Mas depois temos todos os restantes que podem ter cursos muito diferentes, ou polifásicos, isto é, ou policíclicos, em que têm alturas de agravamento e alturas em que estão bem, em que é de melhoria, e depois temos aqueles que também podem ter uma doença persistente e aí com formas artríticas muito graves, que dão poliartrites extremamente destrutivas e incapacitantes. Uma associação também com o antigênio de histocompatibilidade com o HLA-DRP11 mostra-nos que todo o perfil de assinatura celular imune que daí decorre sugere-nos também que estas doenças tenham também um perfil de autoimunidade e não só de autoinflamação, isto é, não seja só a imunidade inata envolvida, mas também a imunidade adaptativa. E daí nós termos muitas vezes um modelo bifásico de doença em que não temos só manifestações sistémicas, mas temos depois manifestações articulares extremamente graves. Tudo isto é extremamente importante, extremamente desafiante para nós compreendermos melhor esta doença, que de facto é a doença mais grave de todas as artrites juvenis. Aqui só para elucidar um bocadinho a febre cotidiana, isto são doentes que nós temos internados, e o rash evanescente, que aparece sobretudo nas raízes dos membros superiores e inferiores e no tronco e raramente noutros locais. Aqui é uma doente minha que ficou de facto com artrite das temporomandibulares e depois ficam com este fenótipo de micrognatia, queixo muito pequenino, metido para dentro e que não conseguem abrir a cavidade oral. Chamei a cavidade oral interincisivos é de mais ou menos 4 centímetros e muitas vezes eles não conseguem ver e é uma manifestação que muitas vezes é difícil de observar porque os doentes não se queixam e nós temos que estar muito atentos a alguma assimetria, habitualmente têm pouca dor. Aqui temos só algum raio-x de alguns doentes meus que manifestamente tiveram um envolvimento articular muito grave, nomeadamente da coluna cervical, com artrite das interapofisárias posteriores, coxite bilateral, com destruição completa das coxofemorais, e isto indicia muito um mau prognóstico. Portanto, nós quando vemos crianças com manifestações sistémicas, com artrite sistémica, com envolvimento, sobretudo, da coluna cervical, punhos e ancas, são doentes que habitualmente vão ter um mau prognóstico funcional e muita incapacidade e, portanto, temos que os tratar atempadamente. Os achados laboratoriais, como sabem, não são específicos, são achados laboratoriais que, aliás, o professor Vasconcelos já disse aqui algumas particularidades, mas que não são específicos e que podem aparecer em imensas situações, nomeadamente situações infecciosas e situações tumorais. E, portanto, como sabem, isto é sempre um diagnóstico de exclusão. Há proteínas C reativas muito elevadas, velocidades de cimentações muito elevadas, leucocitoses que muitas vezes atingem 30, 40, 50 mil leucócitos com neutrofilias brutais e que, de facto, o diagnóstico de uma infecção ou de uma patologia hemato-oncológica é urgente de excluir. Habitualmente os anticorpos são negativos e, hoje em dia, há novos marcadores que podem ser importantes para ver a doença. E então, também só para terem uma ideia, muitas vezes isto complica com síndrome de ativação macrofágica, que é uma complicação fatal se não for depressa percebida e que nós atualmente até temos critérios para classificar e que pode aparecer em qualquer altura da doença, mesmo em doentes com remissão. E então os nossos objetivos é tratar o doente, induzir a remissão, prevenir o dano articular, promover o crescimento e é importante verificarmos que a patofisiologia recente destas doenças deram um papel preponderante às citoquinas pró-inflamatórias, à interleucina 1 e à interleucina 6, e que é aqui que nós agora fulcramos o nosso tratamento nos bloqueios destas interleucinas. Aqui têm só eu sei que é muito pouco tempo, deveria ter mais tempo, outra vez tenho que me dar mais tempo de antena. Aqui tem só uma percepção de como é que nós tratamos estes doentes e o que é que nós fazemos atualmente? Atualmente, conhecidos os mecanismos fisiopatológicos, o papel destas interleucinas ou destas citoquinas pró-inflamatórias, e numa altura em que nós tratamos os doentes com tratamentos-alvo, e os doentes pediátricos têm sido um pouco esquecidos em relação aos adultos, nós vamos bloquear aquelas interleucinas para tentar, de facto, que a doença entre em remissão completa, clínica, o mais rápido possível e que não tenha depois a tal incapacidade ou a tal morbilidade e mortalidade. Não devemos, à luz das recomendações atuais, não devemos fazer o tratamento pirâmide, o tratamento escalado com anti-inflamatórios, com glicocorticoides, mas, perante o diagnóstico, começar logo com bioterapia, interleucina 1, interleucina 6, ou depois, na fase em que poderá haver uma destruição articular grande, eventualmente usar os anti-TNF. Portanto, isto é o ponto mais importante e aquilo que nós usamos, vocês sabem, portanto, o anakinra, que é um inibidor da receita da interleucina 1, o canakinumab. O canakinumab tem uma particularidade, e isto são dados muito recentes, é que eles também parecem, além de reduzir o gene de imunidade inata, também têm uma expressão muito significativa na interleucina 6, que nós sabemos que é mais propícia para o aparecimento de alterações articulares. Portanto, o tocilizumab, por exemplo, nós usamos em primeira linha muitas vezes quando as manifestações articulares na apresentação da doença são mais graves. O canakinumab parece, de facto, atuar não só nas manifestações sistémicas como nas articulares e daí também estar, de facto, validado para as artrites idiopáticas juvenis poliarticulares. Isto são alguns preditores de resposta à doença, cada vez nós queremos mais terapêuticas à medida, e isto parecem ser alguns preditores de terapêutica, de resposta à terapêutica, que é muito importante, e nós queremos rapidamente fazer com que a doença entre em remissão. Nós sabemos que isso é possível muitas vezes até um mês após o início destas terapêuticas, e muitas vezes ao fim de um ano temos os doentes em remissão completa e podemos suspender a terapêutica biológica. Isto são algumas mensagens só que eu vos queria dar, que é muito importante a reclassificação das artrites idiopáticas juvenis e que de facto a artrite fique de fora dos critérios de diagnóstico. É muito importante saber que devemos só usar a corticoterapia, os esteroides nas manifestações muito severas de doença ou se houver um síndrome de ativação macrofágica, mas iniciado imediato os inibidores das interleucinas o mais rápido possível e claro que futuramente vamos ter, e já estão em estudo, novos biomarcadores e novas citoquímicas que poderão ser também úteis para a nossa orientação terapêutica. E então eu achei muita piada ao vosso tema do casamento entre a autoimunidade e a medicina, e eu aqui também acho que deve haver um casamento na artrite sistémica entre a desregulação da imunidade inata e da autoimunidade, e espero que esse casamento dure muitos anos e que nos traga bons filhos e bom futuro. Muito obrigada por tudo.
Thank you. Thank you very much, Professor Iva Brito. We will discuss later. So now it's my pleasure to present Professor Eugene Feist from, hello, how are you? Professor Eugene Feist is the medical director of the biggest private clinics in Europe, I think, the Helios Clinic. He studied in Kiev Institute and Berlin University. He worked in Charité Hospital, and now he is chief physician of rheumatology in that LU clinic, and he is very interested in the field of autoimmune and autoinflammatory. So, Professor Feist, thank you very much, and please, the stage is yours.
Yeah, Professor Vasconcelos, dear colleagues, thank you very much for this kind introduction. And thanks also to Professor Brito for this beautiful presentation on systemic idiopathic juvenile arthritis. Yes, indeed, I would like to touch now on the adult form of the same disease, as we believe still is the same disease in children as well as in adults. However, discussions are still ongoing, and we have to watch the development of the next years. But it is a fact that the disease was first described by Sir Still, a British pediatric colleague, more than 100 years ago. And only 50 years ago, the adult colleague Baywaters described the same condition in adults with the same symptoms of disease. However, over the past decades, we have not reached uniform classification criteria for children and adults, and we still struggle with many issues with delayed diagnosis. We have to raise awareness, of course, about this disease. We still struggle also with different treatment recommendations, if there are any. We struggle also with non-defined outcome parameters, no evaluated scores, at least for the adults. However, we have learned a lot in the past years. We have understood better the pathogenesis of disease. We now consider it to represent an autoinflammatory disease, meaning also that the adaptive immune system does play a role, but a minor one. The major driving force of the disease comes from the cytokines interleukin-1 and interleukin-6. What we also do see in these conditions is a shift from the systemic form of disease, which comes with fever, to the arthritic form of disease, which more represents, I would say, a seronegative severe rheumatoid arthritis. And we do see this progression in chronic forms of this disease in children as well as in adults. The pathogenesis seems to be quite similar. We have investigated this also with the support of Novartis by using well-characterized cohorts of patients with SJIA and AOSD in a clinical development program. We have analyzed their transcriptomic signature, and the result, which is highlighted here, was very similar, irrespective of the age of our patients. So especially the interleukin-1 signal system was upregulated in both conditions. So the signature was pretty much the same And so most of the scientists today indeed think that juvenile and adult Still's disease is a disease continuum or the same disease, which cannot simply separated by the age of 16. By saying so, I think we have also to think about the best way to handle our patients. And one major issue in daily practice is the transition from the pediatric colleague to the adult rheumatologist. For this purpose, whole working group have been established and have worked out recommendations how the transition in young people should be optimized. In Germany, we have registers, especially for the children with SGIA, but we don't have so far a good register for AOSD. We are still working with it. But what the register for the children tells us is that a significant proportion of our patients lose contact after the age of 16 or 18 or 20 to a rheumatologist. They lose the contact and they are not seen by the adult rheumatologist anymore. And this is, of course, a big problem, and we try to solve it by implying a structured process of transition, starting very early with the patient, with the parents, in common discussions between the pediatric and the adult rheumatologist. It takes time, it takes many efforts to do so, but it is, in our opinion, the best way by using such a structured approach really to take care also for our patients in the transition. Professor Brito has already mentioned, I think, very nicely the typical signs and symptoms of disease and SGIA, and they are very similar in AOSD. A systemic disease usually starts with fever, which is accompanied by rash. We name it also the intern's rash because the fever goes, the rash goes away in the morning hours, and is usually only seen by the colleagues on duty during the evening, during the night. However, in the duration of disease, most of the patients will develop not only arthralgias, but also arthritis and many other potential life-threatening complications of this systemic autoinflammatory disease, which is an inflammatory disease because it comes also with an increase in laboratory markers for inflammation. As mentioned already, we don't have so far uniform classification or diagnostic criteria for adults, but also no consensus with our pediatric colleagues. We are working on it, and I think especially the Yamaguchi criteria for the adult patients are considered to work very nicely also in pediatric patients. So there is a shift, I think, also in the classification for children, and maybe one day we even might have a very similar classification criteria for the same disease. Well, the skin manifestation is typically shown here, a salmon-like rash, which disappears if the fever goes away. However, we have seen also variable skin manifestations. Some look even like vasculitic manifestations. The articular involvement is also not uniform. We have patients which only present with arthralgias, but in the for follow-up, they can develop, of course, arthritis. As in the children, we sometimes see a destructive arthritis representing a seronegative rheumatoid arthritis, I would say. But we do also see patients with oligoarthritis or even monoarthritis, so it is not a uniform picture. We should think in two dimensions. I think in Still's disease, we have to understand that the systemic form of the disease is really something different from the pure articular form and should be maybe even treated in a different way, because also the cytokine signature could change by time. Saying so, I would like to introduce case of a patient with Still's disease which looks very similar to what we would really name seronegative rheumatoid arthritis. At that time, it was a 32 years lady with a symmetric polyarthritis accompanied by fever. And if you have a look on this finger and wrist joints, I think everybody would simultaneously say this looks like a ray. However, she had fever and she had a very high ferritin level, but negative autoantibodies. So how to treat such a patient? It is now, I think, 20 years ago that she was in our clinic at the Charité. We started in the usual way by at that time trying to improve her symptoms by NSAIDs, then glucocorticoids, but she was not able to reduce it below the required level. Finally, we tried several conventional DMARDs, which was not effective enough. At that time, we tried also TNF blockers, but she was refractory to this approach. And she was, I think, really the very first patient in our clinic at the Charité at that time, which received an interleukin-1 inhibitor. And she really responded within few days. Later on, after the response was lost to anakinra, we tried tocilizumab, but under tocilizumab, she developed an allergic reaction, and finally, she moved on to canakinumab. So in her case, really, we tried everything which is now considered to represent a targeted therapy for AOSD. Well, especially for interleukin-1 inhibitors in adults, we have nice data from many cohorts, especially our Italian colleagues have done a beautiful work in multi-center studies. Most of this data comes from non-controlled clinical trials, some from retrospective analysis, but they all show uniformly that interleukin-1 inhibition works. It decreases the overall score, which is named after our French colleague Pouchot, but it also improves the arthritis in these patients significantly. And in fact, some of this data even suggest that interleukin-1 works quite similar in patients with articular manifestation compared to those who have a pure systemic manifestation. So maybe there is not a huge difference in between these two phenotypes of patients with respect to the response to the interleukin-1 approach. So it seems, at least from this study from our Italian colleagues, that both phenotypes respond well. This was also the idea of our study, which we did at the Charité together with several other centers in Germany. We named this study Consider. It was an investigator-initiated placebo-controlled trial, the only one which does exist for canakinumab and AOSD. And although it was an interleukin-1 inhibitor, we focused really in this trial mainly on the articular manifestation of disease. So our primary outcome was improvement of the articular manifestation. According to our statistics, we need 68 patients to find a significant difference. However, we were not able to complete the study until the end because canakinumab, which was used as an interleukin-1 blocker in this trial, was approved by the EMA before we were able really to fill our study with all required patients. So the planned primary outcome was at week 12, so at a very early time point, and this is the study design. This slide shows you the baseline demographics of our patients, highlighting that this was a heterogeneous cohort. Many patients had a long-lasting disease. Many of them, in fact, more than 70% were treated by a biologic previously, so a really difficult to treat group of patients. And as mentioned before, we were not able to recruit the full study, so we were also not able as a result to find a statistically significant difference. However, there was a difference, a clear difference in favor of canakinumab compared to placebo with respect to improvement of DAS28 and thus Euler response. And we also observed a clear and now also significant difference if it comes to secondary outcomes. And if you used ACR response criteria, especially also the ACR30 modified response, which also takes fever into account. So the results in our eyes were convincing enough. The safety was no surprise, so the same safety profile as already known for interleukin-1 inhibitor as canakinumab. And finally, we submitted these results together with Novartis to the FDA, and the FDA also following the decision by the EMA approved the drug for AOSD now not only in Europe but also in the US. So I think finally this gives good opportunity for our patients, really, especially in life-threatening systemic complications, to start quite early with an interleukin-1 inhibitor. And you are all aware, I think, that in Europe, at least, we also have the approval nowadays for anakinra in the treatment of AOSD. So finally, this gives us a shortcut, the option really to treat severe patients which are in need for a targeted therapy very early on with targeted therapies. And this is maybe also the way really to use the window of opportunity which has been described in children so far in different studies, showing that early start of targeted therapy is really something which changes the course of disease, which improves the long-term outcome, as already mentioned by Professor Brito. And we also have to consider that Still's disease can evolve into a life-threatening scenario with many different severe complications. I highlighted the macrophage activation syndrome here because Still's disease in children as well as in adults is the most frequent rheumatic condition who can cause a macrophage activation syndrome. And you know, this syndrome is always life-threatening. It comes as a puzzle of different findings of cytopenias accompanied by fever, accompanied by cytokine storm, and most of the patients finally end up at the intensive care unit, where the rheumatologist has to be involved really to figure out what is going on and to understand that this is a condition, macrophage activation syndrome, which should be under the umbrella of all the different syndromes that we know nowadays, representing a cytokine storm. And this is, of course, then the best maybe the best way really to understand how the disease works, because here the cytokine blockers are really necessary to stop the cytokine storm. If you don't make the diagnosis early, then the prognosis of the patients with macrophage activation syndrome is bad. Really, we know that compared to those patients who do not develop macrophage activation syndrome, the mortality is really dramatic in these conditions. And usually macrophage activation syndrome is something which will appear in children as well as adults during the first months of disease. But there is also a risk over the full duration of the disease for developing a macrophage activation syndrome. And so I think, in summary, we have to understand not only the pathogenesis of Still's disease better in the future, but we should try to find predictive markers to separate the different forms of disease from the mild form, which maybe only comes with one flare and then never appears again, something that we can maybe only treat with glucocorticoids, separate these forms from those who will progress to a chronic articular type, where we can apply all the treatments which we also do use for RA. And finally, really, this is I think the most important task, to identify early and to raise awareness for the severe systemic activity, where we should not hesitate really to use targeted therapies early on. So a lot to do for us in the future, together with our pediatric colleagues. A lot of work is currently ongoing in networks all over Europe. We are working together, for instance, in a group which is named DAVID, which will develop and validate new activity score in ASD. We are in very close cooperation, as mentioned before, also to find new classification criteria for children and adults. And I think this is a very fruitful strategy to work together with our pediatric colleagues in this area. Thank you very much for your attention.
Thank you very much for an excellent presentation. So we have time for discussion, but now I will start, well, before Raquel, I will start asking you, how many of you is a still disease patient? How many? Well, a lot. Laurent, how many still disease in your apartment in Renault? Right? In our apartment, Teresa, quantos? 8, 10? Right, 8, 10. Okay. Zé? Também? Oh, good Lord. So, a lot of patients, doctors with still disease. So, question, Raquel, please.
Thank you. This is Raquel from Porto. Eugene, I was with you in Copenhagen, so I was your student from your group in Copenhagen. And I really appreciate your presentation and all you have been done for still adult onset still disease. The question actually is for both of you. In which patient, if not all, and that's provocative, would you consider testing for monogenic autoinflammatory diseases?
So maybe I can start with an answer. Yeah, it's a very interesting question because we have now, of course, much better options also to test for monogenetic diseases by using panel diagnostics. And I think also the costs for such testing will decrease in the years to come. So it will be much easier in the future to test for monogenic diseases. So far, we don't do this in Still's disease. I think it is of interest, of course, if the costs would be lower to check and to rule out other diseases. But in most of the cases, the clinical picture is so typical, in my mind at least, so typical for Still's. I don't recall any other autoinflammatory or autoimmune disease which could be misleading here really if the picture is complete. But you are right, of course, if the picture is not complete, then we have to rule out many diseases, starting with infections, further hematologic, oncologic disorders, of course, autoimmune diseases like lupus, etc. And maybe if this is not enough, and if the picture is still not clear from the clinical point of view, even a genetic testing for other monogenetic conditions could be appropriate. But if the picture is classical, let's say fever, venescent, salmon-like rash, arthralgias, plus very high ferritin levels or calprotectin levels, S100 levels, which are used also now, not only in children, but also in adults. If this picture is clear, then I would not hesitate to make the diagnosis fast.
Well, Professor Iva Brito also answered the same thing. So not practical routine and only the severe and difficult, not clear-cut still disease.
O estudo genético nas formas destes síndromes febris periódicos raramente se pede, nós pedimos habitualmente estudo genético quando de facto estamos perante quadros um pouco diferentes, destas formas de febre periódica, em que habitualmente, mesmo o quadro clínico reveste-se habitualmente de manifestações muito diferentes. Ou naquelas formas em que nós tínhamos algumas dúvidas, as formas mais graves, desculpe, em que nós temos de facto muita dificuldade em perceber se estamos perante uma forma poligénica pura. E, portanto, é só nessas alturas.
I'll already translated. Come on, Zé.
English.
Yes, English. Or Danish.
Okay. It's a very practical question in terms of clinical approach. You said, and this is particularly for the pediatrics, that treating early, diagnosing early, treating early is extremely important. But you said that the step that Printo did by changing the classification criteria was very important for that. Classification criteria should not change early diagnosis. So why do you wait for the classification criteria to make the diagnosis?
No.
Which leads me to the second question. How many of those patients do you feel that it's not a still? Why do you wait?
Bom, eu penso que, aliás, naquilo que explicitei, penso que ficou mais ou menos claro, que o diagnóstico de uma artrite idiopática sistémica é difícil, porque é sempre um diagnóstico de exclusão perante um quadro febril sustentado. É complicado. E é sempre um diagnóstico de exclusão, porque de facto as patologias infecciosas e tumorais são muito mais frequentes. A objetivação de uma artrite, como eu disse, não é sempre possível fazê-la no início do diagnóstico. E nos critérios atuais que nós temos, é necessária e obrigatória a objetivação de uma artrite. E isso nem sempre é possível. A maioria das vezes não é possível. Ela surge muito tempo depois. Claro que nós, perante um quadro em que nos parece que de facto tem critérios ou cumpre critérios por exclusão de uma artrite idiopática sistémica, não vamos estar à espera que apareça uma artrite para tratar estes doentes. Quando nós já verificamos que o tratamento precoce faz toda a diferença na remissão clínica imediata e na progressão para doença não artrítica ou com até aparecimento de um síndrome de ativação macrofágica.
So, Professor Eva, she recognized the problem of the criteria classification, but she do not wait to start off-label treatment. Off-label.
Off-label.
Well, you have
Mais ou
no
menos.
more questions. So, you have experience with anakinra and canakinumab?
A lot of experience.
Diga,
É assim, de facto, cada vez mais, perante um quadro que nós reconhecemos como até provável de doença de Still, eu só muito rapidamente despisto patologia infecciosa grave ou patologia tumoral. E depois, na percepção de que posso estar perante um quadro de doença sistémica, de uma artrite sistémica, eu praticamente começo logo com os inibidores de interleucina. Como é que eu faço? Uma perspectiva muito prática. Se as manifestações sistémicas são preponderantes, começo por um inibidor de interleucina 1. Se houver um componente artrítico já manifesto, então posso optar, por exemplo, por um inibidor da interleucina 6. Isto depois é um bocadinho conforme o doente que nós temos à frente. Os glucocorticoides eu reservo-os para aquelas situações de manifestações sistémicas muito graves ou quando, de facto, isto indicia um quadro de ativação macrofágica. Mas mesmo iniciando os glucocorticoides, eu inicio também, mais ou menos de forma concomitante, os inibidores das interleucinas, porque isso vai fazer diferença, de facto, na resposta terapêutica e na progressão da doença.
Thank you. Professor Eva has experience with anakinra and canakinumab. And tocilizumab also. She started steroids, but with biological in order to reduce the dose of steroids. Okay, so Eugene, tell me, you can tell me that the gene's expression is a continuum, but this is rare. This has two clear subsets. So what happens? Genes do not explain mostly 30% or something like this, like in autoimmune diseases. So is it the environmental? What factors do you see, do you think are predisponent to the onset of disease?
That's a great question, and we don't have an answer so far. Indeed, what we are doing is we are describing the picture, and we did it also on the transcriptome level. So it's not about the genome, it is about the transcriptome, what is really activated in the patients. And I have mentioned that the EMA gave their approval to canakinumab before we were able to finish our clinical study. Their decision, and this is, I think, something very unique, I have never heard about a similar decision, was mainly based on our transcriptomic analysis. So I did not believe that it will work, but it worked in the end. So what we did after we finished our biomarker study, which was ready, of course, before the clinical trial was finished, what we did was to submit together with Novartis this data of the transcriptomic analysis, which is, let's say, the translation of the clinical manifestation in the genetic molecular level. We submitted this material together with which was also already known about Still's disease, about disease continuum, etc., to the EMA. And they made their decision solely on the very convincing transcriptomic data. So I think this was a very wise decision in the end. And it highlights also that sometimes, at least, authorities are really innovative and can really do something which you would not expect in a good way.
Thank you. We have more time. Questions? If not, oh yes, sir. Yeah, please.
Eugene, this one's for you. Jose from Mamadora here, around here. Very quick. In the articular phenotype, in a predominantly articular phenotype, where they almost mimic a seronegative rheumatoid arthritis, as you mentioned, do you think there's a role for secukinumab, anti-IL-17? And if so, which patients would you choose to address that?
Yeah, very interesting question. So, of course, you are right. We have now also novel biologics, including interleukin-17 inhibitors, for which we have some case reports showing that they can be of value. We have also case reports for JAK inhibitors in Still's disease. So there is much more to investigate in the years to come. So it's not only about interleukin-1, interleukin-6 inhibition. We have interleukin-18 as a target. We have interleukin-17 as a potential target. And we have also the interferon signature as a potential targets where the JAK inhibitors could play a role. But this is now, let's say, in the warm-up phase. First, I think we really need to finalize our David study group work to really have good, reliable, validated outcome parameters. And this will help us then in the future to perform beautiful clinical trials, investigating all these others very interesting approaches.
So, Eugene, what are the biomarkers you really use in clinical practice, and what are the red flags for in a patient that put you aware of a not good evolution?
Mm-hmm. Yeah, so the basic biomarkers are CRP, neutrophils, ferritin, and in addition, also the S100 proteins, namely calprotectin, which is measured in serum and also show high levels, especially in Still's disease. All these markers are not specific.
Yeah.
However, if they have high levels, very high levels, their specificity becomes better by excluding, obviously, a septic condition, for instance. It would be very interesting also to have interleukin-18 available in our lab, but only very few labs are doing it on a routine basis. So very few labs will offer this marker nowadays, at least. So interleukin 18 would be something I would also wish to have on a daily basis, but it's not available everywhere. The red flags are indeed those patients where you see cytopenia, where cytopenia comes together with fever, and where all these signs of macrophage activation syndrome appear. And sometimes it starts not as a full macrophage activation syndrome, but as something that we call pre-macrophage activation syndrome. So only part of the criteria is fulfilled. And this is already, of course, a red flag. Another red flag is if we have cardiac or pulmonal involvement, which is also something associated with Still's disease in the adults especially, and where we also now understand that these patients are very difficult to treat, and we should make the diagnosis very early on. So this is also another bundle of red flags, pulmonal and cardiac involvement.
Like in rheumatoid
I would
arthritis-
like,
sorry.
if I
Yes,
can,
you-
Carlos.
I thought you were in the slide.
I am on the flight, but I am here too.
Yehuda Shon
They
from Tel
divided
Aviv.
me.
Come on.
My dear Carlos, you started the session with mentioning our description of the hyperferritinemic syndrome. And just now it was mentioned early diagnosis. And I would like to say that the hyperferritinemic syndrome, which include mass, catastrophic antiphospholipid, etc., also the COVID syndrome, it's hyperferritinemic syndrome. And for years, we have struggled to show what is the role of the ferritin. Is it just epiphenomenon for diagnostic purposes, or is it involved? And we found that it's activating the inflammation. And therefore, we came with an idea to treat, to lower the level of the ferritin. And we had a paper with Carlo Pericone, also with Rusciti, that Piero Rusciti that was cited by in the wonderful speech. So maybe we should see or follow constantly the ferritin in this patient. When we see the surge and the increase, then to start a preventive therapy to reduce the level of the ferritin, not the cytokine. The cytokines actually are the results of the ferritin activating the macrophages. Thank you.
Thank you very much. Thank you very much, Yehuda, for your comment. So now we are in the end. Thank you very much, Professor Eva Brito and Professor Eugene Feist. I knew, and you all saw that a lot of doctors here present have seen still disease patients. And indeed, there are drugs that we can use. There are some rules, and indeed, it is not the case that I lived 20 years ago when it was in 93, 94, when I called to Japan to talk with Professor Yamaguchi. It was an experience at that time, talk to Japan. So again, thank you to Novartis, and we move on. Thank you very much.
We must move on because we are a few minutes late. And now we are going to listen again Renaud Felton about tailored therapy in systemic autoimmune diseases. Is it artificial? We listened before, yesterday and today, this morning. presentations on SLE, RA, APS, and in the next presentation about Sjogren's syndrome. And why about systemic autoimmune diseases? Is it artificial or not? Renaud is going to answer to this. Thank you.
Once again, thank you very much for inviting me to talk about this topic. But in fact, I will talk about the distinction about conventional systemic, synthetic, biologic, and targeted synthetic disease-modifying anti-rheumatic drugs. Is it an artificial distinction? When we are talking about tailored therapy, it's an interesting question. Here are my disclosures. The first proposal for this new nomenclature was published in the IRD a few years ago by Joseph Smollen and collaborators. And on the one hand, you have synthetic DMARDs with conventional one and targeted synthetic ones. And on the other end, you have biologic DMARDs with originator and biosimilar. It has been used again in the last recommendation from EULAR for the management of rheumatoid arthritis. But in fact, in France, we have a different nomenclature with the conventional synthetic on the one hand and the targeted ones on the other end, with synthetic, targeted, and a biological one. So in fact, what is the purpose of this distinction? Is it to separate immunomodulators from immunosuppressants? Is it to separate treatments by mode of action, targeted versus non-targeted ones? Is it to prioritize treatment in the therapeutic strategy? Or is it to just talk about new treatments, such as targeted ones versus old one, conventional synthetic ones? So the first question is it to separate immunomodulators from immunosuppressants? And what is the definition of immunomodulators and immunosuppressive drugs? In fact, immunomodulators do not increase the risk of infection or cancer, whereas immunosuppressive drugs do increase this risk. So in fact, the risk of serious infection in a patient treated by methotrexate has been extensively studied, and in systematic review and meta-analysis, this risk was overall increased in methotrexate patients. In the Lancet journal, the risk of biological treatment has been assessed in a systematic review and meta-analysis, and you have here the results. Overall, there is an increased risk on the top of the graph here of biological treatment, and this is increased when patients are methotrexate experienced, and there is a dose-depending in a dose-depending manner. More recently, tofacitinib and JAK inhibitors has been available. So the risk of this treatment has already been assessed. And in that study, an interesting thing is that we could compare the risk between some biological, such as abatacept, with a risk of serious infection of 3 per 100 patients per year, compared to tocilizumab 5, infliximab 6, or other TNF inhibitors with a risk of 5. JAK inhibitors here with tofacitinib is around 3 per 100 patients per year. When we are talking about the risk of infection under biologic, we have to think about more specific data regarding some infection. And we have just published in IRD a letter about the risk of severe COVID-19 in patients treated by intravenous biologic in day hospital in France. And this risk is not the same. There is a clear increased risk of severe COVID with rituximab compared to infliximab, tocilizumab, or abatacept. This has to be taken into account. So the overall perspective about the infection risk is that this risk is low under conventional synthetic DMARDs, but it exists. And the risk under biological is variable depending on the molecule. And overall, the risk of infection is a little bit lower with targeted synthetic DMARDs compared to biological ones. For the risk of concern, this is a synthesis of the literature. And you may notice that overall, most of DMARDs have an increased risk of skin cancer. And for the JAK inhibitors, you may be aware about the oral surveillance study, which has not been yet published, but available in clinicaltrial.gov, which assessed an increased risk of solid cancer with tofacitinib. When we are facing a patient with an history of cancer, we should use rituximab because there are some data with no documented increased risk in that population. Whereas in a patient treated by abatacept, recent data has shown that in meta-analysis, the total malignancy risk is a little bit higher with abatacept versus other biological or targeted synthetic DMARDs. We can understand this increased risk when we are considering the checkpoint inhibitors treatments that we are using in cancer when we are blocking CTLA-4 compared to the action of CTLA-4 immunoglobulin in array. So the overall perspective for this cancer risk is there is another risk of solid cancer for most DMARDs, even for conventional synthetic ones. The risk with biological ones are variable depending on the molecule. And for TS-DMARDs, the risk is demonstrated with tofacitinib, but is there a class effect or is there a molecule effect? It remains to be demonstrated. So in fact, the only immunomodulators that we are using is hydroxychloroquine or sulfasalazine, and all the others are immunosuppressive drugs. The second question is this distinction made to separate treatment by mode of action, targeted versus non-targeted one? And you can see here the simplified mode of action of methotrexate, which is targeting dihydrofolate reductase and thymidylate synthetase, inducing an inhibition of purine base synthesis. So you can wonder if it's a targeted therapy. But in fact, in a very interesting paper published in Nature Review Rheumatology, the mode of action of methotrexate is more complex, dealing with a decrease in purine production, but also an adenosine release, and so other mode of action. The mode of action of biologic, you are all aware with this mode of action. It's really targeted therapies, targeting TNF-alpha, IL-6 receptor, or CD20, for example. For JAK-STAT pathway, the mode of action is a little bit different with intracellular signaling pathway with a dimerization and phosphorylation, inducing expression of transcriptome and transcription of pro-inflammatory genes. In fact, very numerous and several receptors are using this pathways, these downstream pathways, and actually currently we could block these pathways with tofacitinib, baricitinib, upadacitinib or filgotinib. But is this really targeted therapies when we are blocking all the downstream pathway of all the cytokines? It's a good question. Here is the mode of action of glucosteroids. I think you won't consider glucosteroids as targeted therapies, but in fact, glucosteroids are diffused into the membrane and then targeted the receptor of the glucocorticoids and then induced the transcription or the repression of some genes, in fact, as the same as JAK inhibitors. So what is exactly a targeted therapy remains a good question. The third question is that this distinction is made for prioritized treatments in the therapeutic strategy. You are all aware about the recommendation concerning rheumatoid arthritis. In fact, after the phase 1, you can consider adding a targeted therapies, biological one or JAK inhibitor, and in the phase 2, in a case of failure, you can switch for another one. But in fact, some JAK inhibitors has been studied in more early phases in before methotrexate therapy. And in that study, begin study, baricitinib has been compared to methotrexate in patients with no more than 3 doses of methotrexate. The primary endpoint was ACR20 at week 24 with 3 arms, the methotrexate alone, baricitinib alone, or baricitinib plus methotrexate. Here are the main results. You may notice that baricitinib alone or baricitinib plus methotrexate is superior to methotrexate alone in that patient. It was the same for the radiographic results assessed by the delta sharp score. So in first-line RA patient, baricitinib alone or in combination with methotrexate appears to be more effective than methotrexate alone. It was the same for another study assessing filgotinib, the Finch 3 study, in patients who have not yet received methotrexate with 4 arms, filgotinib plus methotrexate with 2 dosage, filgotinib alone or methotrexate alone. And the results were the same with a superiority of filgotinib with methotrexate or alone compared to methotrexate. The same for radiographic evolution or for remission. So filgotinib was also more effective than methotrexate alone or with methotrexate than methotrexate alone. So will be JAK inhibitors moved as a first-line therapy in the years to come is a remaining question, but they will have to provide reassuring data about safety. The last question is that the distinction is to differentiate the new treatments as targeted ones versus the whole treatments as conventional ones. In fact, we have conducted with Laurent a systematic review of the clinical trials that were done in rheumatoid arthritis. And we have identified more than 240 molecules that has been developed or are currently developed in RA. Most of them are biological one or targeted synthetic, but there remains some conventional one. You can see here that that among the 22 conventional one, 8 are already marketed, and you may know them. Conventional treatment targeting the DNA synthesis, and 12 have been already withdrawn. So in fact, conventional DMARDs are not immunomodulators, and we have to vaccine our patient and take the risk of infection into account in that patient. The distinction between conventional synthetic, biological, or targeted synthetic DMARDs is currently adapted to talk about the different classes, but do not forget intra-class differences such as infectious risk or cancer risk, which is not the same between biological, for instance. And it's adapted for the current therapeutic strategy and association of background therapy. Indeed, you will not add a targeted synthetic therapy to a biological one, or in only exceptional cases. But what is a really targeted therapy is a remaining question. And we will likely see an evolution of the use of therapy in the years to come. Thank you very much.
Thank you, Renaud. You presented as all the old and new therapeutics and the evolution to the future. Why do you think that JAK inhibitors are going to move to the first line? Why do you think that?
I used to think that before the oral surveillance data, but since we have more specific safety data that are a little bit worse than biological one, I don't think that JAK are moving to first-line therapies unless we are showing safety data for other molecules.
And they are more safe, of
Yeah.
course. Any questions from the audience?
Thank you, Renaud. Very nice talk. And it's nice to see the things from this view. And the last sentence, or almost the last, is very interesting for me, is what is really a target therapy? When it's target therapy, treat to target, it's a confusion for me, because by one side, and it is the disseminated side, it's a target, a clinical target, ACR, CDI, SLEDAI, and so on. But by the other side, target therapy for me would be a therapy that target the immunopathway involved in the disease. So this is a confusion. This is a word that makes a lot of confusion. And so you divide the immunosuppressors, as we can see, and but should we divide the biological? We are seeing biological as a whole, a group, but it seems an universe. So what can we do to see more clear?
Yeah, I totally agree with you. Thank you for this comment. In fact, it is a family, but they are not so there are some differences. So we might be aware of these differences and considering as a family, but in fact there is so much difference and intra-family differences that we would take into account. Yeah.
That you tailored therapy according to the risk of infections, the risk of cancer, and the patient, but we are not targeting according to the pathways. Can we do? Why do you choose inhibit JAK instead of inhibit TNF?
Yeah, it's another way to think about tailored therapy. It's to target the pathogenesis. I also agree with you. In fact, some patients are more TNF driven, more B cell driven, maybe with the synovial biopsy. We should and we could maybe identify patients with more pathogenesis. Yeah, it could be interesting, but there are so many way of talking about tailored therapy, I have just focused on that one. Yeah, yeah.
Any more questions or comments?
Yeah, just a very quick question, comment. Thank you very much. It's a very nice talk. Do you think that actually the true distinction is biologics versus chemical therapy? Not very useful in practice, but the reason why biologics are called biologics is because they are produced by living organism, genetically engineered, and all the others are just chemically synthesized.
Yeah,
you think it's
maybe.
relevant?
Yeah, it's a good question. Maybe it's a good separation, because these differences are not logical. But in fact, there is also some differences in the subfamily. So it has to be taken into account too. Yeah.
Thank you. More questions? If not, we are going to finish. Thank you, Renaud.
Thank you.
So good morning. We are going to move to the last presentation of this morning. And I start to present Professor Manuel Ramos Casals. He works in the Department of Autoimmune Disease of the Clinic Hospital in Barcelona. He's currently the national coordinator of the working group of systemic autoimmune disease of Spanish Society of Internal Medicine. Professor Ramos Casals is an internationally considered an opinion leader in Sjögren's syndrome. We have the pleasure to hear him about tailored therapy in Sjögren's syndrome. Professor, welcome to our meeting, and we are very sorry for the delay of your presentation.
Don't worry. Thank you very much for your kind words, and thank you to Professor Vasconcelos to invite me. It's a pity not to be here with you, but I think that we could have a nice and useful presentation for all of you. I'm starting to share my here it is. Can you see my screen
Yes.
correctly? Okay, so let's start with the proposal that Carlos suggests for my presentation. This is the usual disclosure slide, and this is the manuscript of the EULAR recommendations for the management of Sjögren's syndrome that we published in Annals of Rheumatic Diseases in 2020, and that I will use to make this presentation about how to tailor the therapy of in patients with Sjögren's syndrome. And this is the guide that I would like to propose to follow in the next 20 minutes. I will start the time in order to have this time correctly. So, and we'll start the presentation with the first topic, that is the how we can tailor the therapy of Zika symptoms in patients with Sjögren's syndrome. So we can start with analyze the approach for the oral dryness, one of the most frequent symptoms of these patients. And for oral dryness, we recommend that the therapeutic approach should be always driven by a baseline measurement of salivary glandular function, and not by the patient's subjective feelings. The reason of suggesting or recommending this baseline evaluation of glandular function is that the classification of how the salivary glands are functioning, it will be very, very useful to tailor what could be the therapeutic approach for oral dryness. In this regard, we can classify patients with oral dryness according to this analysis of the salivary gland dysfunction in patients having mild or moderate dysfunction. We can use the salivary hull measurements of the salivary flows or the salivary scintigraphy. And using this objective diagnostic test, we can classify patients with a dysfunction, with the corresponding dysfunction of the salivary glands. And for patients with mild and moderate dysfunction, the recommendations as first-line therapeutic approach is the use of non-pharmacological stimulation using mechanic or gustatory mechanisms. And in patients with moderate salivary gland dysfunction, the second-line therapeutic approach we recommend is the pharmacological stimulation using pilocarpine or cevimeline drugs, the muscarinic agonists. And for those patients who showed in the study severe dysfunction, that is the lack of residual glandular function, in these patients, the approach is totally different, and we recommend the use of saliva substitution. The reason, I think that it is easy to understand, because these patients have no glandular tissue for having a stimulation, and due to the lack of this glandular function, the only approach that we can offer to these patients is the substitution of the saliva. What about the management of ocular dryness, that it is together with oral dryness, the more frequent feature symptoms of patients with Sjögren's syndrome? So the first-line therapeutic approach is absolutely clear, is the recommendation in all patients with Sjögren's syndrome of the use of artificial tears and ocular gel or ointments. And once again, we need to try to have a clear definition of the severity of the damage of the corneal surface that is made by the ophthalmologist, because in patients in whom the severity is clearly demonstrated by the studies using the standard scores used by the ophthalmologist, the OSD is one of the most recently proposed. In patients with this severe ocular surface disease or that are refractory to the standard therapy with artificial tears, we recommend as a first option the use of topical glucocorticosteroids in a maximum length of 10 days, 10 consecutive days, but or in patients with severe disease or requiring multiple use of this short time use of topical ocular corticosteroids, the use of topical cyclosporin A. And as third and fourth lines of therapeutic approach that are always managed and recommended by the ophthalmologist, the use of serum eye drops, or in some cases, the use of block insertion. We close the first block of the tailored therapy for Zika syndrome, and we start a second part of the talk about how we can tailor the therapy for the systemic Sjögren. And we start with one of the most frequent and disturbing symptomatic problems in patients with Sjögren syndrome, the coexistence of musculoskeletal pain, chronic pain, and fatigue. And the recommendations are clear. We can consider the use of analgesics or other pain modifying agents, always logically considering the balance between the potential benefits and side effects. And specifically for patients with acute pain, we can use paracetamol or non-steroidal anti-inflammatory drugs for targeting a symptomatic relief, and always not much more of 10 consecutive days. In patients who present with frequent episodes of acute pain, we could recommend the use of hydroxychloroquine, despite that most controlled studies that we have in Sjögren are not positive. We think, and this is a consensus between all the members of the task force, that in these patients we can try to use hydroxychloroquine in order to see if we can reduce at least the frequency of these acute pain episodes. And also clearly for patients with chronic pain, non-pharmacological management, and to recommend physical activity, aerobic exercise, but we not recommend the use of drugs for treating chronic pain associated with Sjögren syndrome. And what about the global approach for systemic Sjögren, for systemic disease? It is also a clear recommendation to treat, tailoring the treatment to the organ-specific severity using the SDI definitions. The SDI, as probably most of you knows, is the currently accepted international score to measure and to define the systemic activity of Sjögren syndrome. And we propose as an overall rule that systemic therapies could be considered for most patients presenting with one of these two general options. The first is that the patient present at least moderate activity in one clinical SDI domain, or in those patients in whom the global score was at least of 5 points. We will focus on the main therapeutic options for treating Sjögren syndrome, and the first is corticosteroids, that are often the first-line therapy for most of the systemic involvements in Sjögren syndrome. And as you can see, and this is, I think, a general rule, an international rule, to use the minimum dose and length of corticosteroids necessary to control activity, and for moderate presentations using a dose not higher than 0.5 milligrams per kilo per day, and always considering for severe systemic presentations the use of pulses of methylprednisolone. And for the withdrawal of corticosteroids, as soon as possible, or at least trying to target a maintenance dose of 5 milligrams daily or less, with the aid of corticosteroid sparing agents. That is the next slide. The role of immunosuppressive agents in patients with Sjögren syndrome. The key role of this type of drugs in Sjögren syndromes is the use of corticosteroid sparing agents. And unfortunately, we not have any evidence that can support the choice of one of these drugs over another. Are also clear. Some patients that may require long-term therapy with corticosteroids, especially those with severe organ impairments with a logical potential development of chronic damage. These are the targeted population to use the addition of immunosuppressive agents to the corticosteroid therapy. Once again, always weighing the potential benefits and risk of any of these drugs. And what about biological agents? We have also a clear consensus opinion that rituximab may be considered in patients with Sjögren's syndrome presenting with severe refractory systemic disease. And probably the best indication in Sjögren for the use of rituximab is the association with a cryoglobulinemic vasculitis. And what could be the plan, the use of the combination of these different therapeutic options in Sjögren's syndrome? Once again, we recommend this organ-specific approach based on the definitions included in the SDI classifications. And as you will see, for most inflammatory severe systemic manifestations, the first-line approach is based in glucocorticosteroids use, with the exclusion of features included in the constitutional, lymphatic, and glandular domains. But the use of corticosteroids are recommended as first-line therapy in patients with arthritis, with vasculitis, with interstitial lung disease, with glomerulonephritis, with multineuritis or vasculitic neuropathy, or vasculitic involvement of the central nervous system, and in patients with severe cytopenias, including hemolytic anemia or idiopathic thrombocytopenic purpura. And a second-line approach or third-line situations on presentations that are severe or as rescue therapy. As you can see, different combinations of rituximab, oral immunosuppressive agents, in some cases, such as hematological, the use of intravenous immunoglobulin, and in the most severe cases, the addition, especially in patients with associated vasculitis, of plasma exchanges. But we have another scenario, another organ-specific scenario that can be managed without, or should be managed without, the use of corticosteroids. And in this scenario, we include symptoms from the constitutional domain: fever, low fever, weight loss, other features, fatigue, etc. The enlargement of lymph nodes that are not related, obviously, with lymphoma, non-severe involvement of the parotid glands, arthralgias, inflammatory cutaneous lesions, non-vasculitic cutaneous lesions, skin lesions, the bronchial involvement, the tubular involvement of the kidneys, and for non-vasculitic neurological features. Logically, we need to move to the third part of the presentation, that is the future of targeted therapies in Sjögren's syndrome. We will quickly review this recent publication about this update of targeted therapeutic options that we published with Soledad and other colleagues. And quickly, there are 5 different pathological scenarios that could be target or that the new drugs are trying to target in patients with Sjögren's syndrome. The first is the targeting of dendritic cells or antigen presentation cells with small studies and trials that at this time the results are not impressive, not enough positive. The second scenario is targeting T cells and the cytokines related with the activity of T cells. And as you well know, the use of infliximab is not associated with a significant improvement. And we also have negative results for tocilizumab and anakinra. The third scenario is targeting T-cell B-cell crosstalk, and the data are also limited and not excessively optimistic, with negative results for abatacept and some suggested positive signals for other drugs like lolizumab and maybe for iscalimab, this drug targeting CD40 ligand. The scenario typical and classical that are associated with probably most positive, more optimistic results are targeting B cells, despite the negative results of the rituximab on the main features of Sjögren's syndrome, Zika and general features. But we have some positive signals about the use of other anti-CD20 agents and some other positive signals for blocking the BAF, the BLIS system, and some data in 20 or 15 years ago about the potential efficacy of the use of eprotuzumab. And finally, the most recent scenario for trying to target Sjögren's syndrome from a therapeutic point of view is the intracellular targeting with the use of small molecules blocking, for example, P13K, JAKs, SYK, and other BTK and other intracellular kinases. And unfortunately, most of the data that we have that are small trials and small studies are having negative results. So it does seem that this therapeutic approach could be positive for patients with Sjögren's syndrome, but we need large trials for confirming this lack of efficacy in the disease. And we would like to finish the talk with reviewing with you or providing with you some remarks that could be useful for your daily practice. First, the limitations, the huge limitations that we have in treating Sjögren's syndrome. And in regard of this, we should be considered that this is a true orphan disease from a therapeutic point of view, because we have, because the absence of any efficacious agent. And in comparison with other diseases, we have a very limited high quality scientific evidence of trials carried out in patients fulfilling the current classification criteria. There are probably a dozen of controlled trials, and most of these trials including less than 100 patients and less than 50 patients in each arm. So the powerful of these trials are not enough. And as a conclusion of this limitation is that we are very far from the disease modification concept as the mainstay of treatment of Sjögren's syndrome as used, for example, in other diseases that you know, such as rheumatoid arthritis. And for clinical practice, I think that the overarching principles of the EULAR recommendations can be useful. because the scenario for tailoring therapies for the dryness symptoms is clear. The intervention is overwhelmingly focused on the use of topical drugs, and the target should be the symptomatic relief, not the cure of these symptoms. And for systemic, the scenario is different. The intervention are based on the use of systemic drugs, and the target is to try to cure the organ involvement. And final, and I think that interesting for clinical practice, these top 5 wrong therapeutic decisions that we could take in patients with Sjögren's syndrome. The first is the use of muscarinic agents, for example, pilocarpine, in those patients lacking salivary gland function. There is no sense to use drugs that are searching the stimulation of these glands that are not functioning. The second is the use of topical cyclosporin A or ceramide drops in patients in whom there is no demonstration of a severe involvement of the corneal surface. So it is always recommended the specific study by a ophthalmologist about the diagnosis of this severity of the ocular dryness. The third wrong therapeutic decision is the use of systemic therapies, corticosteroids, immunosuppressive agents, biologics, for treating Zika features, fatigue, or chronic musculoskeletal pain. The fourth wrong decision is the use of corticosteroids in a higher dose of 1 milligram per kilo per day, or the maintenance of more than 5 milligrams per day when the patient is inactive or the systemic activity is controlled with a treatment. And finally, another wrong therapeutic decision is the use of rituximab in patients presenting low or moderate SDI, or the use of rituximab as a first or second line therapeutic option, with one exception, the presence of a concomitant cryoglobulinemic vasculitis in these patients. We recommend the use at least a second line option due to the good therapeutic response. And this is all. I think that it could be useful for all of you, the presentation, and thank you very much for your attention.
So is there any questions for the professor?
Thank you very much, Manel. Very clear presentation as usual. Tell me, perhaps I missed, but did you talk about belimumab? If there is a hope that belimumab could act, is one question. And the second one is, Sjögren has subgroups like lupus, and we know it's difficult trials and so on, but what is, in your opinion, the main reason for trials failure in Sjögren patients? Thank you.
Okay, good points. The first question is about belimumab. I think that the only or the more solid study that we have about the use of belimumab in Sjögren's syndrome is one open label study that I think that in 30 patients with Sjögren's syndrome that is led by Xavier Mariette and Salvatore De Vita. And the results are positive, especially for some specific features like glandular parotid glandular enlargement, but we don't have at this time a controlled trial showing that belimumab may be superior to the use of the placebo arm for treating systemic active disease. In this scenario, with this limited evidence, scientific evidence, it was difficult for the task force to make a specific point about the use of belimumab for Sjögren's syndrome. There are also, I think that there are also some small trials trying to analyze the effect of combination of rituximab and belimumab following the model of lupus, and some isolated cases published, I think that also by the group of Salvatore De Vita and Luca Quartuccio, about the potential use of this sequential therapy, and also by Xavier Mariette about the sequential use of rituximab and belimumab in some selected cases. But in the light of having a solid recommendation about the use of belimumab, I think that we don't have a clear statement, and maybe some people will think that it could be an option for patients not responding to rituximab, but it is not clear. I think that it is very difficult to have a clear position of belimumab. And with respect with why we are having another negative trial in Sjögren's syndrome. Probably there is a mix of reasons that can explain these usual negative results. One is also observed in patients in trials who using other biological agents in lupus, that is the use in the control arm of corticosteroids as baseline therapies. But I think that the main reason is the election of what are the outcomes, especially the primary outcomes that should be measured as a therapeutic response for Sjögren's syndrome, because the history of the trials in Sjögren's syndrome always learned to all of us that the choice of the main symptoms of the disease, that are the dryness, the fatigue, and the chronic pain, in all the trials that these features are chosen as the primary outcomes, the results have been always negative. And I think that the influence of the environmental factors in patients with Sjögren's syndrome about the intensity and the severity of these symptoms is too high and that can be explained why there is always no difference between patients treated with the active biological agent and those treated with placebo. Probably the placebo effect in these symptoms, in these that are the more frequent symptoms, is difficult. It is much more objective to measure systemic activity, probably using a combination of organ targeted damage and biological biomarkers. And in trials, in most trials with negative results about clinical response, the biological markers, in contrast, have a good response. And this is difficult to understand, but we have no practical learning for these findings to find the improvement of, for example, of CRP, of erythrocyte sedimentation rate, or even gamma globulinemia or cytokines, but we have never find clinical response when we centered on these symptoms. So I think that we have a lot of work about searching and thinking what could be the good outcome, probably a composite score, including the main phases of the disease, not also these subjective symptoms, but also objective tests of glandular dysfunction and systemic activity could be a better option for the future trials that we could develop.
Just to confirm, hydroxychloroquine only in articular symptoms and a subset of patients. So you don't use in a generalized form?
No.
Okay.
No. We have the scientific evidence against the general recommendations following the recommendations for patients with lupus, because the pivotal trial of the use of hydroxychloroquine in patients with Sjögren's syndrome that leads Jacques-Eric Gottenberg, once again has negative results for the main outcomes, and the main outcomes are dryness, chronic pain, and fatigue. So having this evidence, it is not possible to recommend the generalized use of hydroxychloroquine in patients with Sjögren's syndrome, but the clinical experience of most of us show that in some patients with acute pain, hydroxychloroquine could be benefits. And because we don't have any other alternative of using another drugs, and the profile of safety of the hydroxychloroquine with the retinal examinations, etc., is good, we can recommend from a weak position the individual use of hydroxychloroquine in some patients with articular involvement.
Is there any questions? So thank you, Professor.
You're welcome.